Mingalaba, good afternoon. My name is Ram Zydus Kadila. It is my pleasure and privilege to welcome Professor Mimicho, the chair for today, Professor Vimite, our co-chair, Professor ASN, our speaker, Professor A, our speaker, and from the international, we have Dr. Arvind Sharma, who is joining us to deliver this lecture from India. So, welcome you all. And also, I welcome Dr. Amrut Naik, our President, EMB from Zydus Kadila. And I extend my warmest welcome to all the clinicians from Yangon, Mandalay, Upper Myanmar, Lower Myanmar for taking their time out in joining this today's launch of Migo, a symposium. And I also welcome the family members of Zydus who has put a lot of efforts for conducting this mega event, because we have registered more than 400 doctors for this event, and it should be more than, when we are going to end this session. And we all know that we are facing challenging time with the COVID, which is made to unlearn and relearn and the way we live. Similarly, it is time for us to really unlearn and relearn about migraine. And today's symposia about updates management 2020 would definitely help each one of us the way we look at migraine. And we have experience of Professor Mimicho, Dr. Vimite, Professor ASN, Professor Semia A, Dr. Arvind Sharma share their experience in tackling migraine. And just to know about Zydus, Zydus is a very house to each one of you. We started our journey 20 years back, and as most of you may be knowing that Zydus has put our factory in Tilawa, and it is ready to go from October. So that is a moment we are all expecting. And Zydus taken initiative in bringing and improving the quality of life of everyone living in this universe. Meaning of Zydus dedicated to life. And as you know, Zydus is fighting with all other community and other companies COVID, and very happy to share all the developments. We are one of the few companies trying to put a lot of research in tackling COVID in different way, and we have remdesivir as one of the drug which is approved, and we are extremely happy to inform you that Zydus is already entered the phase 2 of the COVID vaccine, and we are hopeful that maybe by end of the year we will have some solution in the form of vaccine from Zydus. So that's a happy time for us. So flow of the event, the agenda I just read out for the benefit of all of us. So after my welcome, there will be introductory remarks by our chair, followed by migraine and mimics by Professor ASN, followed by practical tips for acute treatment of migraine by Professor Semyame A, followed by landscape of migraine management and treatment by Dr. Arvind. And there will be question and answer session. So I request all the audience, all the participants, when the speaker finish their presentation, you can type your question in the comment box. So we will compile all the questions, and my colleague Tintin He will read out the questions to the chair and suitably direct the questions to the respective speakers. And also we have something in the called offer. When you see in the when you click the offer, you will find we are giving you a challenge, migraine challenge, migraine Migo challenge. So by clicking that, like we are saying that, you can request for sample and you can try using our product. and we will ensure that the sample is delivered at your doorstep. So once again, thank you all for being here, present here for this wonderful event to start. And we are really privileged to have such a, I would say, if I say that the mother of neurology for Myanmar, it is not just mere exaggeration, because her dedication, her continuous support for the development of neurology in Myanmar, each one of us know this none other than our motherly, excellent clinician, Professor Mimi Cho. I have, from my bottom of my heart, I welcome and thank Professor Mimi Cho, and I request to take up from here and to really make this session a great one. Thank you very much.
Good afternoon, ladies and gentlemen. It is indeed a great privilege for me to take a chair at this webinar on Update in Migraine Management. Migraine is a chronic neurological disorder characterized by attacks of moderate or severe headache and irreversible neurological and systemic symptoms. It is a leading cause of disability worldwide, extracting a huge economic burden on global economies. Population-based studies have shown that approximately 6% of men and 18% of women suffer migraine attacks, and over 80% of these suffer some degree of headache-related disability. Knowing more about the key neural network and neurotransmitter involved during the various phases of migraine may improve our understanding and management of the condition, which may also open doors to focused therapeutic options. There are several headache disorders mimicking migraine. The topic on migraine and its mimic will be presented by Professor Asa, Senior Consultant Neurologist from University of Medicine to Yangon. She graduated on April 1996 from University of Medicine, Mandalay, and achieved Master of Medical Science, Internal Medicine on 2005, and Doctorate in Neurology on January 2013, and MRCP UK on March 2014, and FRCP in December 2016, and Diploma in Medical Education in December 2018. Now, may I invite Professor Asa for her presentation, please.
Siaro Siamaro Alome Mingla Bounty Piso Mazi, Tamao mix a pere, Mamma de Goa, deep symposium leo, Pimia, Kuni Sound Pere, Zydus Gerilao, Jesu Tenshija, Yinzo, Yoja Luvare, Tamadini swimming met topics caro, migraine and its mimic sura, comes in a swimming matipare, migraine jamne, Tune Pomaya be Nana, Kankate Jam, Utama, swimming matipare. Da jama presentation li ye outlines li ba အဲ့တော့ပထမဆုံးကတော့ migraine ဆိုတာဘာလဲပေါ့နော် migraine က it's a common intermittently disabling and usually inherited neurologic disorders that has a tendency to neuronal hyperexcitability ဟိုအရင်တုန်းကတော့ဒီ migraine ဟာ vascular process လို့သူတို့တွေကထင်ခဲ့ကြပေမဲ့နောက်ဆုံးသိရှိချက်အရဆိုလို့ရှိရင်တော့ဒါက neuron process ပဲဖြစ်ပါတယ် neuron ကပဲဒီ migraine process ကြီးကိုအစပြိုးလိုက်တယ်ဆိုပြီးတော့တွေးရှိလာကြပါတယ်ဒီ neuron ကactivate လုပ်လိုက်တဲ့အတွက်ကြောင့်မှသာလျှင်နောက်ဆက်တွဲ vascular hormonal manifestation တွေရပြီးတော့လူနာတွေမှာလည်း autonomic manifestation တွေဖြစ်လာတယ်လို့တွေးရှိလာကြပါတယ်migraine ကဘာကြောင့်အရေးကြီးသလဲပေါ့နော်ကျမတို့ဒီ global burden of disease study 2016ကိုကြည့်လိုက်မယ်ဆိုလို့ရှိရင်ကမ္ဘာပေါ်မှာပေါ့နော်ဒီ migraine ဟာ global burden of disease ထဲမှာနံပါတ်12နေရာမှာရှိနေပါတယ်အဲ့ဒီအပြင်ကိုသူကဒီ disability နဲ့တွက်ကြည့်လိုက်မယ်ဆိုလို့ရှိရင်သူကနံပါတ်4နေရာမှာသူကနေရာယူထားပါတယ်ကမ္ဘာပေါ်မှာလူ3သန်းလောက်ဟာတဲ့ migraine နဲ့ tension type headache တွေရနေကြတယ်ဖြစ်ပွားတဲ့ပမာဏကိုကြည့်လိုက်မယ်ဆိုရင်တော့ tension type က migraine ထက်2ဆလောက်များနေတယ်ဆိုတာတွေ့ရပေမဲ့လို့လေဒီ disability ဖြစ်တဲ့ပမာဏကိုတိုက်မယ်ဆိုလို့ရှိရင်တော့ migraine ဟာ tension type ထက်6ဆခွဲလောက်ပိုများနေတယ်ဆိုတာကိုတွေ့ရမှာဖြစ်ပါတယ်ဒါကြောင့်မလို့ဒီ migraine ဟာပေါ့နော် disability ကိုအဖြစ်ဆုံးဖြစ်နေတဲ့အတွက်ကြောင့်မလို့အရေးကြီးတဲ့ယောဂတစ်ခုဖြစ်ပါတယ်အဲ့တော့ migraine ကဘယ်ဒီမှာပိုဖြစ်လဲဆိုလို့ရှိရင်အမျိုးသမီးတွေမှာပိုဖြစ်တယ်အသက်15နှစ်နဲ့49နှစ်ကြားမှာပိုဖြစ်တယ်ဆိုတာကိုတွေ့ရပါတယ်ဒီ graph လေးကတော့ migraine ပေါ့နော်male နဲ့ female မှာဘယ်သူမှပိုဖြစ်တယ်လဲဆိုတာကိုပြထားတဲ့ graph လေးပါရှေ့မှာပြောခဲ့တဲ့လိုပဲ female တွေမှာပိုဖြစ်များပါတယ်အသက်15နှစ်နဲ့အသက်50ကြားမှာပိုဖြစ်တာဆိုတာကိုတွေ့ရပါတယ်ဒီ graph လေးကတော့ migraine ကြောင့်မလို့ပေါ့နော် disability ဖြစ်စေတဲ့ဟာကို attention headache နဲ့ရှင်းထားတဲ့ graph လေးပါရှေ့မှာပြောခဲ့တဲ့လိုပဲ migraine ကဒီ tension headache test ပို့ပြီးတော့သူက disability score ပိုများစီတာတွေ့ရမှာပါအဲ့တော့ migraine ကိုဘယ်လို classification လုပ်တယ်လဲဘယ်လို diagnosis လုပ်တယ်လဲကျမတို့လေ့လာကြည့်အောင် migraine ကို classification နေနဲ့ migraine without aura migraine with aura chronic migraine complications of migraine probable migraine နဲ့ episodic syndromes that may be associated with migraine ဆိုပြီးတော့ classification 6ခုခွဲထားပါတယ်အဲ့တော့ diagnosis ကဘယ်လိုလုပ်မလဲThe International Classification of Headache Disorder 3 ပေါ့ beta criteria ရဆိုလို့ရှိရင် migraine without aura ကိုဘယ်လို diagnose လုပ်လဲဆိုလို့ရှိရင်ခေါင်းကိုက်တာဟာအနည်းဆုံး9ခါနဲ့အထက်ရှိရမယ်။နောက်အောက်မှာဖော်ပြထားတဲ့ criteria B to D နဲ့လည်းပြည့်စုံရမယ်။ criteria B ကဘာပြောလဲဆိုလို့ရှိရင်ခေါင်းတစ်ခါကိုက်လို့ရှိရင်သူက4နာရီကနေပြီးတော့မှ82နာရီအတွင်းကြာရမယ်။နောက်ခေါင်းကိုက်တာရဲ့ characteristic ဟာလေ unilateral location, percentile quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity ဆိုတဲ့၄ခုတည်းကအနည်းဆုံး2ခုရှိရပါမယ်။နောက်ဒီကကြတော့ ဒီခေါင်းကိုက်နေတဲ့အချိန်အတွင်းမှာဆိုလို့ရှိရင် nausea and vomiting, photophobia ဆိုတဲ့အချက်တွေကအနည်းဆုံးတစ်ချက်နဲ့ကိုက်ညီမှုရှိရပါမယ်။ဤကတော့နောက်ဆုံးပြန်ချုပ်ထားတာကတော့ no better accounted by another ICHD3 diagnosis ပေါ့နော်။ဒီ ICHD3 diagnosis တခြားခေါင်းကိုက်တဲ့ diagnosis တွေနဲ့ကိုက်ညီမှုရှိရဘူးဆိုပြီးတော့ပြောပါတယ်။အဲ့ဒီမှာဒီနံပါတ် E ကnot better accounted by another ICHD3 diagnosis ကဘာကြောင့်ထည့်ရတယ်လဲဆိုလို့ရှိရင်ကျမတို့ကဒီ headache ရဲ့ classification ကိုလုပ်တဲ့အခါမှာ diagnosis လုပ်တဲ့အခါမှာ clinically လုပ်တာဖြစ်တဲ့အတွက်ကြောင့်လို့ပေါ့နော်ဒီ clinical diagnosis တစ်ခုကိုသတ်မှတ်မယ်ဆိုလို့ရှိရင်အများအား differential diagnosis ပေါ့တခြားခေါင်းကိုက်တာကိုဖြစ်နေမလားဆိုတဲ့ဟာလေးကိုပြန်ပြီးထည့်စဉ်းစားဖို့ပေါ့နော်နောက်ဆုံးချက်အနေနဲ့သူကချုပ်ထားတဲ့အချက်ကလေးတစ်ခုပဲဖြစ်ပါတယ် Now migraine with aura ပေါ့ migraine with aura ကိုဘယ်လို diagnose လုပ်နေဆိုလို့ရှိရင်ခေါင်းကိုက်တာအနည်းဆုံး2ခါနဲ့အထက်ရှိရပါမယ်။အောက်မှာဖော်ပြထားတဲ့ criteria B နဲ့ C နဲ့ကိုက်ညီမှုရှိရပါမယ်။ criteria B ကတော့ aura symptoms တွေဖြစ်တဲ့ visual, sensory, speech or language, motor, brainstem, retinal ဆိုတဲ့6မျိုးတွေကအနည်းဆုံးတစ်ခုရှိရပါမယ်။အဲ့ဒီ aura symptoms ကလည်း fully reversible ရှိရပါမယ်။ criteria ကြီးရကြတော့ဘာဖြစ်လဲဆိုလို့ရှိရင်ဒီခေါင်းကိုက်တဲ့အရာရဲ့ aura ရဲ့ characteristic ဟာဆိုလို့ရှိရင် aura ဟာ9မိနစ်အတွင်းမှာ spread ဖြစ်သွားရမယ်။ဒါမှမဟုတ်လို့ရှိရင် aura symptoms နှစ်ခုဟာစတိုက်ပေါ်လာတာမျိုးဖြစ်ရမယ်။သို့မဟုတ်ဒီ aura symptoms ဟာဆိုလို့ရှိရင်9မိနစ်ကနေပြီးတော့မှမိနစ်60အတွင်းကြာရမယ် unilateral ဖြစ်ရမယ်ဒီ aura symptoms ပေါ်ပြီးတော့တစ်နာရီအတွင်းမှာခေါင်းကိုက်တာလိုက်လာရမယ်အဲ့ဒီအချက်၄ခုတွေကအနည်းဆုံး2ချက်နဲ့အထက်ရှိရပါမယ်နောက်ထုံးစံအတိုင်းတခြား ICH-3 headache diagnosis တွေမဖြစ်ရဘူး TIA မဖြစ်ရပါဘူးNow chronic migraine ဆိုတာကြတော့ဘယ်လိုသတ်မှတ်မလဲဆိုလို့ရှိရင်ခေါင်းကိုက်တာဟာတစ်လမှာ15ရက်နဲ့အထက်ကိုက်တယ်3လစက်တိုက်ကိုက်တယ်အဲ့ဒီခေါင်းကိုက်တာကလည်းတစ်လမှာပေါ့နော်10ရက်နဲ့အထက်ဟာ migraine ဖြစ်ဖြစ်ရမယ်ပေါ့နော်ဒါဆိုလို့ရှိရင် chronic migraine လို့ခေါ်ပါတယ် chronic migraine လို့သတ်မှတ်ဖို့ဆိုလို့ရှိရင်ခေါင်းကိုက်တဲ့တိုက်ဟာ tension တိုက်ခတ်တဲ့မဖြစ်ရပါဘူး Now, complications of migraine နေနဲ့ဘာတွေရှိနိုင်လဲဆိုလို့ရှိရင် status migrainosus ရဲ့ persistent aura without infarction, migrainous infarction, migraine aura trigger seizure ဆိုပြီးတော့ရှိပါတယ်။ Now, နံပါတ်5ကလည်းအားလဲဆိုလို့ရှိရင် probable migraine ပေါ့ probable migraine ဆိုတာကတော့ကျွန်မရှေ့မှာပြောခဲ့တဲ့ပေါ့နော် migraine subtype တွေလည်းဝင်ဖို့အတွက် criteria တွေကတစ်ချက်လိုနေတယ်ဆိုလို့ရှိရင် probable migraine လို့ခေါ်ပါတယ်။နောက်ထုံးစံအတိုင်းတခြား headache disorders တွေနဲ့ကိုက်ညီမှုရှိရပါဘူး။အဲ့တော့ probable migraine မှာ probable migraine with aura နဲ့ probable migraine without aura ဆိုပြီးတော့ပြန်ပြီးတော့ခွဲခြားပြီးတော့ diagnose လုပ်နိုင်ပါတယ်။ Now, episodic syndromes that may be associated with migraine နေနဲ့ဘာတွေရှိနေဆိုလို့ရင် recurrent gastrointestinal disturbances တွေဖြစ်တဲ့ cyclic vomiting syndrome တွေ abdominal migraine တွေဖြစ်နိုင်ပါတယ်အထူးသဖြင့်ကလေးတွေမှာပိုတွေ့တတ်တယ်လို့ဆိုပါတယ်နောက်တစ်မျိုးကတော့ benign paroxysmal type နဲ့လည်းလာတတ်ပါတယ်နောက်တစ်ခုကကျတော့ benign paroxysmal torticollis အနေနဲ့လည်းလာနိုင်ပါတယ်သူတို့တွေကတော့ခေါင်းကိုက်တာမဟုတ်ဘဲနဲ့ပေါ့နော်ဒီလိုမျိုး symptoms တွေနဲ့လည်းလာတတ်ပါတယ်အဲ့တော့ migraine ရဲ့ clinical features တွေကဘာတွေရှိမလဲကျမတို့လေ့လာကြည့်အောင်အဲ့တော့ migraine attack တစ်ခုမှဆိုလို့ရှိရင်သူက premonitory ရဲ့ oral ရဲ့ headache ရဲ့ postdrome ဆိုပြီးတဲ့အခါကျတော့သူက stage ၄ခုရှိပါတယ်migraine attack တစ်ခုနဲ့ကြားထဲမှာဆိုလို့ရှိရင် interactive phase ဆိုတာလေးရှိတယ်အဲ့ဒီ interactive phase မှာဆိုလို့ရှိရင်လည်းလူနာတွေဟာ trigger factors လေးတွေရှိတတ်ပါတယ်အဲ့တော့ interactive phase မှာ migraine ကို trigger လုပ်နိုင်တဲ့ဟာတွေကတော့ဘာတွေလဲဆိုလို့ရှိရင် genetics ရဲ့ environmental ရဲ့ metabolism ရဲ့ drugs ရဲ့ hormones ရဲ့ဆိုပြီးတော့ရှိပါတယ် Now, premonitory phase ကဘာကြောင့်ဖြစ်လာသလဲဆိုလို့ရှိရင်ဒီ hypothalamus မှာ changes လေးတွေဖြစ်တာကြောင့်တော့၎င်း occipital cortex မှာ activation ဖြစ်တာကြောင့်တော့၎င်းဒီ trigeminal cervical complex မှာ central sensitization ဖြစ်တာကြောင့်၎င်း upper cervical nerve တွေ activation ဖြစ်တာကြောင့်၎င်းဒီ premonitory phase မှာ symptoms လေးတွေပေါ်လာတာပါအဲ့တော့ hypothalamus နဲ့ ventral tegmentum မှာ changes တွေဖြစ်တဲ့အတွက်ကြောင့်မလို့လူနာဟာ polyuria mood changes in appetite နဲ့ yawning တွေနဲ့လာနိုင်ပါတယ်ဒီ occipital cortex activation ဖြစ်တဲ့အတွက်ကြောင့်မလို့လေ light sensitivity တွေရတတ်ပါတယ်ဒီ upper cervical nerve activation ဖြစ်တဲ့အတွက်ကြောင့်မလို့လူနာ neck pain တွေနဲ့လည်းလာနိုင်ပါတယ် central sensitization to trigeminal cervical complex ဖြစ်တဲ့အတွက်ကြောင့်မလို့သူက periorbital pain တွေလည်းရတတ်ပါတယ်Now, oral phase ကရောဘာကြောင့်ဖြစ်တယ်လဲပေါ့ oral phase ကတော့ဒီ visual cortex activation ဖြစ်တာကြောင့်အများဆုံးဖြစ်ပြီးတော့တ Currently, the cortical spreading depression, so activities later on, the non-visual symptoms delay, yada pare. Visual symptoms de anemia or bari yamne solutions, kutumata bono, amego diminari, photopsia, phosphine stick, nenelemianali, twinine, now geometric forms anene twinine, fortification spectra yame. Currently, go binama share objects take up or no, rotate kinime, don't canime, oscillate kinime. Currently, ocean brightness, hallucination, or distortion, or metamorphosis, or macropsia, rule, yanamare. Arabian, the cortical spreading depression activities the activation process they are the time cortical areas take gule, nine non-visual symptoms non-visual symptoms solution, sensory solution paresthesia olfactory hallucination motor weakness or ataxia language ma dysarthria, aphasia delusions distant consciousness Now, face the kuaro or a being like lama headache. Headache a solution, the Jurama Shia arteries, vasodilation, extravasation, first sensitization, central sensitization process now cortical spreading, depression, download pinare, now sent to the vasoactive peptide stage the headache surava, tipolarava. Local solutions are typically unilateral. The pepe strobing to severity solution moderate to severe intensity. The company solution bilateral headache the solution come at the pekka not the pekko the catalytic solution paying a neck to shura radiated Kankai needed a chamber or laga, Kankai be a chima or laga dunaha, skept and unnecessary delay, Janai Mare. The time associated symptoms the anemia, gastrointestinal anemia, anorexia, nausea, vomiting, food craving, Yanai Sensory symptoms anemia solution of photophobia, phonophobia, osmophobia, now lightheadedness, fatigue, blah vision, nation stiffness delay, Yanai Now, post-drome or now face the kuaro. I know post-drome are bazang to the lay so the exam mechanism are but with the blam, the analysis studies are the solution. The post-drome are symptoms they have a pre-monitoring phase ma. The activity brain areas they got subiro active needed to example the post-drome symptoms the polar do subare. Now we may study the kuaba the solution. Mahobu, Dadi, post-drone symptoms, the pre-monitoring phase name at the side move to my unique mechanism to cushy ebono. And a ballet solution in it. Gankai Bidwabi solution, the brain areas to Tomyama, blood flow in Negara, Kazamalo Dunaha, post-drone symptoms, the Sinara, Lusuare. Dunaga, mentally solution, to impair concentration in a name, darkness, the yame, wash out effective irritability, listlessness for no, Lulone, Sictonia, Lurine, Danamare. Physically in a solution or muscle weakness, head pain, aching, anorexia, food craving, Danamare. Tomorrow case lady ne dilazia da case number 1ပေါ့နော်19နှစ်တက္ကသိုလ်ကျောင်းသူလေသူက3လအတွင်းမှာခဏခဏခေါင်းကိုက်ပြီးလာတယ်။တပတ်မှတစ်ခါလောက်သူကိုက်တယ်။သူဘယ်အချိန်ကိုက်လဲဆိုရင် class B ရဲ့အချိန်ဆိုကိုက်တယ်။ခေါင်းကိုက်တဲ့ character ကတော့ဘုံမင်းပေါ့နော်ထိုးပြီးတော့ကိုက်တယ်။ခေါင်းလုံးကိုက်တယ်။ခေါင်းကိုက်နေတဲ့အချိန်တွင်မှဆိုဘာမှမလုပ်နိုင်ဘူး။ကလထိုင်မှာသွားလှဲနေရတယ်နော်။လူရှင်ရဲ့သူအတန်တိတ်တာကိုပို့ပြီးတော့နှိမ့်သက်တဲ့ခေါင်းကိုက်တဲ့အချိန်မှာဘာမှမကြားချင်ဘူးအဲ့ဒီခေါင်းကိုက်တာရဲ့3ခါလောက်မှတော့သူမျက်စိထဲမှာသူ jet lines လေးတွေမြင်တယ်အဲ့ jet lines လေးတွေကတစ်ခါဖြစ်ရင်15မိနစ်လောက်ကြာတယ်ခါတလေကြားလို့ရှိရင်လည်း stomach upset နဲ့ vomiting လေးတွေရှိတတ်တယ်တဲ့သူကခေါင်းမကိုက်ဘူးဆိုလို့ရှိရင်တော့ကောင်းကောင်းမွန်မွန်ပဲသူစားတွေလည်းသူကောင်းကောင်းလုပ်နိုင်တယ် သူ့အမေမှလည်းသူက premenstrual period မှာခေါင်းကိုက်တဲ့ history လေးရှိတယ်။သူ့မိကလည်းခေါင်းကိုက်ပြီဆိုလို့ရှိရင်လို့မှောင်ငန်းနဲ့မှနေပြီးတော့နေလေးနေရတယ်။ ibuprofen လေးတောက်လိုက်လို့ရှိရင်တော့သက်သာသွားတယ်လို့ပြောတယ်။အဲ့တော့ဒီမျိုးကျောင်းသူလေးရဲ့ခေါင်းကိုက်တာက acetaminophen လေးတောက်လိုက်ရင်တော့တစ်ခါတလေသက်သာတယ်။ဒါပေမဲ့အဲ့ဒီဆေးက more severe habit ပေါ့။ဉာဏ်ကိုက်တဲ့အချိန်ကိုခေါင်းအန်တဲ့အချိန်ကနဲ့တွဲတယ်ဆိုလို့ရှိရင်တော့ဆေးကသူ့ကိုမသက်သာဘူးတဲ့။အဲ့တော့သူ့ကိုစမ်းကြည့်လိုက်တော့ general neurological examination ဟောသွား normal ပဲ။နော် body mass index ကလည်း normal ပဲ။ fundoscopy ကြည့်လိုက်တော့လည်း ability မှာမရှိဘူး။အဲ့တော့ဒီမှာဒီကျောင်းသူလေးမှာဆိုလို့ရှိရင် history မှာရော examination မှာရောသူဒီ reflex တွေမရှိဘူးအဲ့တော့ဒါပါ case လဲဆိုလို့ရှိရင် episodic migraine with aura ပါ now case number 2ပေါ့16နှစ်ပေါ့နော်ကောင်မလေးကသူခေါင်းကိုက်တယ်ဆိုပြီးတော့လာတယ်။ဥယျာဉ်လာတွေကတော့တစ်လကိုတစ်ခါနှစ်ခါလောက်သူကိုက်တယ်။ဒါပေမဲ့6လလောက်ကစပြီးတော့ခေါင်းကိုက်တာပိုပြီးတော့စိတ်လာတယ်ပေါ့နော်။ဒီ6လအတွင်းမှာသူကခေါင်းတစ်ချိန်လုံးပဲသူကိုက်နေတယ်။ဒါပေမဲ့တစ်ပတ်မှ3ခါလောက်ကတော့ကိုက်တာတော်တော်ဆိုးတယ်။အဲ့ဒါကလည်းဒီထိုးပြီးတော့ကိုက်တယ်။တစ်ခါကိုက်လို့ရှိရင်ပေါ့နော် several hours လောက်ကြာတယ်။ခေါင်းကိုက်အဲ့လိုမျိုးခေါင်းအရန်ကိုက်တဲ့အချိန်ဆိုရင်တော့သူကအဲ့ရထဲမှာသွားလှဲနေရတယ်။နောက်ပြီးတော့မှောင်တဲ့အခန်းပေါ့နော်ငြိမ်တဲ့အခန်းလေးမှာငြိမ်လေးပဲသူနေကျင်တယ်ပေါ့နော်တခါတလေကြားလို့ရှင်တော့သူ nausea လေးရတယ် vomiting တော့မရှိဘူးကျန်တဲ့ရက်ပြီဆိုလို့ရှိရင်တော့သူကခေါင်းနည်းနည်းတော့ကိုက်တယ်အဲ့လောက်အများကြီးဆိုကြီးမဟုတ်ဘူး nausea တွေဒီ light sensitivity တွေ photophobia တွေ phonophobia တွေနဲ့မရှိဘူးဒါပေမဲ့လို့သူ့ရဲ့ activities လေးတွေသူလုပ်နိုင်တယ်အဲ့ဒီအချိန်မှာတော့အဲ့တော့ဒီမျိုးကောင်မလေးကို topiramate လေးပေးကြည့်လိုက်တယ်2လလောက်စောင့်ကြည့်တယ်အဲ့ဒါလည်းမသက်သာဘူးနောက် ibuprofen ကလည်းတစ်ပတ်ကို3ခါလောက်တောက်ရတယ်ဒါပေမဲ့လည်းအဲ့ဒါလည်းထူးခြားမှုမရှိဘူး general neurological examination ကတော့ normal ပဲ body mass index ကလည်း normal ပဲ fundoscopy ကြည့်လိုက်တော့လည်း normal ပဲဒါကဘာ case လဲဆိုလို့ရှင်ဒါ chronic migraine ပေါ့နော်ဘာကြောင့် chronic migraine လို့ပြောလဲဆိုလို့ရှိရင်ဒီမျိုးသမီးလေးမှာ underlying migraine history ရှိတယ်။နောက်အခုနောက်ပိုင်း6လမှဆိုလို့ရှိရင်တော့ခေါင်းကိုက်တာတစ်လကိုသူက15ရက်ထဲပို့ပြီးတော့များလာတယ်။နောက် migraine type ပေါ့တစ်ပတ်မှ3ခါလောက်ကတော့ migraine type ပေါ့ photophobia တွေ phonophobia တွေရှိတာကတစ်လကို12ရက်နဲ့ထက်လောက်ရှိလာတယ်။စမ်းကြည့်လိုက်တဲ့အခါမှာ focal neurological sign လေးမရှိဘူး။အဲ့ဒီအတွက်ကြောင့်မလို့ဒါဒီ chronic migraine case လေးဖြစ်ပါတယ်။ now migraine နဲ့ပေါ့နော်ပုံမှားရိုက်ပြီးလာနိုင်တာတွေကဘာတွေရှိသလဲပေါ့နော်ကျမတို့လေ့လာကြည့်ရအောင် migraine နဲ့ပုံမှားရိုက်ပြီးလာနိုင်တဲ့ပထမအုပ်စုကတော့ primary headache disorders တွေပါအဲ့ဒါတွေကဘာလဲဆိုလို့ရှင် tension type headache တွေ trigeminal autonomic convulsions တွေ other primary headache disorders တွေပဲဖြစ်ပါတယ်case number 3ပေါ့နော်35နှစ်เนาะ businessman ကသူခေါင်းကိုက်တာ2လနဲ့လာတယ်ခေါင်းကအိယာထားပြီဆိုတာနဲ့သူခေါင်းကိုက်ပြီ character ဘယ်လိုလဲဆိုလို့ရှင် pressing or tightening ခေါင်းကိုညှစ်ထားတယ်လို့ပဲသူခံစားရတယ် frontal နဲ့ occipital area မှာနှစ်ဖက်စလုံးကိုက်တယ်သူမှာ prodromal symptoms တွေတော့မရှိဘူးသူခေါင်းကိုက်နေတာတော့တောက်လျှောက်တော့ကိုက်နေတာပဲဒါပေမဲ့လို့သူရဲ့ physical activities ကတော့ aggravate သူမလုပ်ဘူးibuprofen လေးတောင်းလိုက်လို့ရှင်တော့နည်းနည်းလေးသူသက်သာသွားတယ် history ပြန်မေးကြည့်လိုက်တော့လွန်ခဲ့တဲ့4လကစပြီးတော့သူကအလုပ်အသစ်လေးတစ်ခုလုပ်တယ်အဲ့ဒီအလုပ်အသစ်တွေကိုသူမှာ stress တွေရှိနေတယ်ပေါ့နော်စမ်းကြည့်လိုက်တယ်သူမှာ ophthalmoplegia လည်းမရှိဘူး focal neurological weakness တို့ meningeal irritation sign မရှိဘူးနောက်ပေမဲ့လို့ဒီ scalp မှာ tenderness လေးတူရှိတယ် fundoscopy ကြည့်လိုက်တော့ normal ပဲနောက် blood test တွေလုပ်လိုက်တော့လည်း normal ပဲ MRI MRA brain လုပ်ကြည့်လိုက်တော့လည်း normal ပဲဒါ case ကပါလဲဆိုလို့ရှိရင် tension type headache ပါပဲအဲ့တော့ tension type headache ကို points လုပ်တဲ့ဟာတွေကဘာတွေလဲဆိုလို့ရှိရင်ခေါင်းကိုက်တဲ့ character က pressing or tightening character ဖြစ်တယ် physical activity ကသူ့ aggravate မလုပ်ဘူးနောက်သူ history မှာ new job with stress history လေးသူမှရှိတယ် history taking examination investigation တွေမှာ reflex တွေသူမှမရှိဘူးဒါကြောင့်မလို့ဒါဒီ tension type headache ဖြစ်ပါတယ် Now case number 4 ပေါ့နော်33နှစ်အမျိုးသမီးကเนาะအရင်တုန်းကသူက tension type headache လေးတွေသူရှိတယ်ဒီလွန်ခဲ့တဲ့3နှစ်ကစပြီးတော့သူက new type of headache လေးရလာတယ်အဲ new type of headache ကဘယ်လိုပုံစံလဲဆိုလို့ရှိရင်ညာဘက်မျက်လုံးက extreme pain ပေါ့အရမ်းနာတယ်တစ်ခါနာလို့ရှိရင်နာရီဝက်လောက်ကြာတယ်တစ်နေ့ကိုတစ်ခါနေ9ခါလောက်နာတယ်အဲ့ဒီတဲ့ဟာကလည်းညာဘက်မှာပဲအများတန်းဘယ်ဘက်မှာတစ်ခါမှမနာဘူးအဲ့လိုမျိုးညာဘက်မျက်လုံးနာနေတဲ့အချိန်ဆိုလို့ရှိရင်ညာဘက်မျက်လုံးကညှိရဲပြီးတော့မျက်ရည်တွေကျတယ်နာနေတဲ့အချိန်ဆိုလို့ရှိရင်သူတယောက်တည်းပဲလူးလှိမ့်နေရတယ်ပေါ့နော်အဲ့ဒီခေါင်းကိုက်တဲ့အချိန်ကလည်းကြည့်လိုက်မယ်ဆိုလို့ရှိရင်မနက်ခင်းအစောကြီး2နာရီဆိုထပြီးကိုက်ပြီးသူ့ကိုအဲ့ရနေနိုးတဲ့အထိကိုသူကကိုက်လာတယ်ပေါ့နော်နောက်တစ်နှစ်မှဆိုလို့ရှိရင်လည်းစက်တင်ဘာနဲ့အောက်တိုဘာ6ပတ်အတွင်းဆိုနေ့တိုင်းကိုက်တော့တာပဲအဲ့အောက်တိုဘာကုန်သွားပြီဆိုလို့ရှိရင်တော့နောက်နှစ်စက်တင်ဘာအထိကတော့သူအရင်ကိုက်နေကြ tension type headache လေးပဲသူဖြစ်နေတယ်ပေါ့နော်သူ naproxen တို့ ibuprofen တို့ acetaminophen တို့သုံးကြည့်တယ်ဒါပေမဲ့တို့လည်းမသက်သာဘူးတော့ဒီလူနာမှာကြည့်လိုက်မယ်ဆိုလို့ရှိရင်နော် cluster headache နဲ့ paroxysmal hemicrania ပေါ့နော်နှစ်ခုရောနေတာကိုတွေ့ရမှာတွေ့အဲ့တော့ female sex ဖြစ်တဲ့အတွက်ကြောင့်လို့သူဒီ paroxysmal hemicrania ပေါ့အများအားကိုက်ရင်ညာဘက်ပဲကိုက်တယ်ဘယ်ဘက်ဘယ်တော့မှမကိုက်ဘူးအဲ့တော့ female မှာသူကပိုဖြစ်တယ်ဒါက paroxysmal hemicrania နဲ့ပိုတူတယ်ပေါ့နော်ဒါပေမဲ့လို့ circadian pattern ပေါ့မနေ့က2နာရီမှထပြီးကြိုက်တယ်เนาะတစ်နှစ်မှဆိုလို့ရှိရင်လည်းစက်တင်ဘာနဲ့အောက်တိုဘာအတွင်းမှာပိုကြိုက်တယ်ခေါင်းကိုက်နေတဲ့အချိန်အတွင်းမှာလည်းလူးလှိမ့်နေအောင်နေရတာကြတော့သူက cluster headache နဲ့ပို့ပြီးတော့တူတယ်အဲ့ဒီ paroxysmal hemicrania နဲ့ဒီ cluster headaches တွေကလည်းတစ်ခါတလေကြာလို့ရှိရင် overlap ဖြစ်တတ်ကြပါတယ်အဲ့တော့ဒါဘာ case လဲဆိုလို့ရှိရင် trigeminal autonomic aphasia ပါ now case number 5ပေါ့နော် case number 5ကအသက်40အမျိုးသမီးသူခေါင်းကိုက်နေတာကိုက်လိုက်ပြောက်လိုက်နဲ့8နှစ်ရှိပြီပေါ့နော်ဘယ်လိုကိုက်လဲဆိုလို့ရှိရင်ဘယ်ဘက်ပဲအမြဲတမ်း throbbing character နဲ့ဖြစ်တယ် photophobia phonophobia တွေရှိတယ်เนาะ nausea တို့ nasal congestion တို့เนาะ left eye မှာ tearing နေတာတွေနဲ့တွေ့တတ်တယ်တစ်လောက်2ခါလောက်ကိုက်တယ်တစ်ခါကိုက်တယ်ဆိုလို့ရှင်လဲ24နာရီလောက်ကြာတယ်အဲ့ဒီအရန်မကိုက်တဲ့တော်တွင်းဆိုလို့ရှိရင်လည်းသူကဘယ်ဘက်တစ်ချမ်းမှာအမြဲတမ်းသူက moderate amount of pain ကအမြဲတမ်းရှိနေတယ်။ဒါပေမဲ့ရှေ့မှာပြောခဲ့သလို photophobia phonophobia တို့ nasal congestion တို့မရှိဘူး။အဲ့တော့ဒီခေါင်းကိုက်နေတဲ့အတွက်ကြောင့်မလို့သူကဘာအလုံးမကိုကောင်းကောင်းမလုပ်နိုင်ဘူးပေါ့နော်။သူရဲ့ daily activities တွေ limit ဖြစ်လာတယ်။ ibuprofen တို့ sumatriptan တို့ rizatriptan တို့ propranolol တို့ venlafaxine တို့မျိုးမျိုးတောက်ကြည့်တယ်။ဒါပေမဲ့လို့လည်းမသက်သာဘူး။သူ့မှာခေါင်းကိုက်တာဟိုပေါ့နော်တက်တာတဲ့နေ့ဆိုတာသူမှမရှိဘူးဒါပေမဲ့အခေါင်းကိုက်တာလည်းအများရန်ပဲညာဘက်လုံးဝမကိုက်ခဲ့ဘူးအဲ့တော့သူ့ကို MRI တို့ MRA head and neck တွေလုပ်ကြည့်တယ် MRV brain လုပ်ကြည့်တယ်ဒါတွေက normal ပဲအဲ့တော့သူ့ကို indomethacin လေးပေးလိုက်ကြည့်တယ်အဲ့တော့ indomethacin ပေးပြီးတော့24နာရီအတွင်းမှာပဲသူဒီ8နှစ်အတွင်းကိုက်နေတဲ့တခါမှ headache free မဖြစ်ဘူးတဲ့ဟာကသူပထမဆုံး indomethacin လေးတောက်လိုက်တာနဲ့သူသက်သာသွားတယ်ပေါ့နော်ဒါပါ case လဲဆိုလို့ရှိရင် hemicrania continua လို့ခေါ်ပါတယ်အဲ့တော့ clues for diagnosis ကဘာလဲဆိုလို့ရှိရင်သူက constant unilateral headache ဖြစ်တယ်ဒီ typical migraine treatment တွေကိုသူက respond မလုပ်ဘူးပေါ့နော် patient တယောက်ဟာ continuous ပေါ့ side lock headache လာတယ်ဆိုလို့ရှိရင်တော့ imaging လုပ်ကြည့်ဖို့လိုပါတယ်ဘာဖြစ်လို့လဲဆိုတော့အထဲထဲက pathology တစ်ခုရှိမလားဆိုတာကိုကျမတို့ရှာဖို့လိုပါတယ်တကယ်လို့ imaging က negative ဆိုလို့ရှိရင်တော့ indomethacin trial လေးပေးကြည့်လို့ရပါတယ် now case number 6ပေါ့နော်85နှစ်အမျိုးသမီးသူက3လအတွင်းမှာ terrible pain ပေါ့နော်သူတသက်နဲ့တကူမှာတစ်ခါမှမနာဘူးတော့ pain ကိုသူရတယ်အဲ့ဒီ pain က paroxysmal လာတာဒီ character ဘယ်လိုလဲဆိုလို့ရှင်သူ့ရဲ့ပါးကိုပေါ့နော်ဒီ electric socket နဲ့တိုးလိုက်တယ်လို့ပဲကျင်သွားတယ်အဲ့တော့အဲ့ဒီနာတဲ့ဟာကဒီပါးနေပြီးတော့မှထိုးလာတယ် radiation to the in front of ear upper lip နဲ့ below left nostril ကို radiate လုပ်တယ်အဲ့ဒီ pain က trigger by talking brushing teeth chewing နဲ့ light wind ကလည်းပိုပြီး trigger ဖြစ်တယ် အဲ့ဒီအတွက်ကြောင့်သူအစာကောင်းကောင်းစားနိုင်မှုမစားနိုင်တဲ့အတွက် weight loss ပါရလာတယ်။ pain ကတနေ့ကိုခဏပေါ့နော်အဲ့လိုမျိုးဖြစ်လိုက်ပြောက်လိုက်နဲ့တောက်လျှောက်ရှိနေတယ်။အဲ့ pain ရတဲ့အချိန်အတွင်းမှာဆိုသူမျက်နှာရှုံသွားပေါ့နော်။အဲ့တော့သူကသွားကြောင်းထင်ပြီးတော့ dentist စီသွားတယ်။ dentist က TM joint syndrome ဆိုပြီး diagnose လုပ်ပြီးတော့ night ကလေးပေးလိုက်တယ်။ဒါပေမဲ့လို့သူမသက်သာဘူး။အဲ့တော့ဒီ dentist ကဒီ left tooth ကို extraction လုပ်ဖို့အတွက် consider လုပ်တယ်။အဲ့တော့ neurologist စီရောက်လာတယ်။ neurological examination လုပ်လိုက်တော့သူဘာမှမရှိဘူးကောင်းတယ်။ corneal reflex တွေရဲ့ trigeminal 5-1 နဲ့ 5-3 distribution က sensory modalities တွေကလည်း normal ပဲ။ဘာလဲဆိုလို့ရှိရင် classical trigeminal neuralgia ပါ။အဲ့တော့ဒီ trigeminal neuralgia လို့ပြောနိုင်တဲ့ပေါ့နော် clues တွေကဘာလဲဆိုလို့ရှိရင် brief lancinating pains strictly limited to the 5-2 distribution of the trigeminal nerve no pain in between ပေါ့နော်ဒါထဲမှာဆို pain မရှိဘူးဒီ severity of pain က swing တို့ tooth brushing တို့ light wind တို့ကနေပြီးတော့မှသူက trigger လုပ်တယ်ဒါဒီ trigeminal neuralgia ပါလူနာတယောက် trigeminal neuralgia နဲ့လာပြီးဆိုလို့ရှိရင်တော့ work up လုပ်ဖို့က MRI brain လုပ်ကြည့်ရပါမယ်ဘာဖြစ်လို့လဲဆိုတော့ CP angle tumor များဖြစ်နေသလားဒါမှမဟုတ်လို့ရှိရင် vascular loop ကများဒီ trigeminal nerve ကို compress ဖြစ်နေလားသိဖို့အတွက် MRI တွေလုပ်ကြည့်ဖို့လိုပါတယ် Now migraine နဲ့ပုံမှားရိုက်ပြီးလာနိုင်တဲ့နောက်အုပ်စုတစ်ခုကတော့ secondary headaches တွေပါအဲ secondary headaches တွေမှာဘာရှိမလဲဆိုလို့ရှိရင်เนาะ headache due to injury to head or neck or cranial or cervical vascular disorders, non-vascular intracranial disorders, substance abuse or its withdrawal, infection, disorders of homeostasis, headache or facial pain attributed to disorders of cranium, neck, eyes, ears, nose, sinus, teeth, mouth, or other facial or cervical structures. Now, headache attributed to psychiatric disorders. The facial pains, the headache disorders. The case lady ne 39နှစ်အမျိုးသမီးပေါ့နော်သူကလွန်ခဲ့တဲ့၄လကအိယာထားလိုက်တဲ့အချိန်မှာပေါ့နော် left sided neck occipital နဲ့ retroauricular temporal pain ကရလာတယ် throat pain in character အဲ့ဒီ၄လအတွင်းမှာခေါင်းကိုက်တာကလုံးဝ consistent ဖြစ်နေတယ်အဲ့ဒီအပြင်ကိုသူကသူ left occipital နဲ့ posterior temporal area မှာ continuous pressure sensation လေးရှိနေတယ်တခါတလေကြားလို့ရှိရင် sharp pain လေးတွေလည်းရရတယ်အဲ့ဒီ sharp pain လေးရနေတဲ့အချိန်မှာဆိုလို့ရှိရင်เนาะသူကအိုက်ဘယ်ဘက်မှာ nasal congestion တွေ oral fullness တွေလည်းသူရှိတတ်တယ်အဲ့ဒီပြင်ကို left sided photophobia တွေရှိတယ် nausea တော့မရှိဘူး neurological examination လုပ်ကြည့်လိုက်တော့ normal ပဲအဲ့တော့ MRI brain လုပ်ကြည့်လိုက်တဲ့အချိန်မှာတော့ဒီ left foramen magnum မှာ meningioma လေးရှိတယ်သူကဒီ medulla ကို right side ကို push လုပ်ထားတာကိုတွေ့ရမှာအဲ့တော့ဒါက example of the headache attributed to non-vascular intracranial disorders ပါ Now case number 8ပေါ့နော် case number 8က42နှစ်အမျိုးသားကသူကလွန်ခဲ့တဲ့နှစ်ပတ်ကဝိမရင်နဲ့ right sided neck pain လေးရလိုက်တယ်အရင်တုန်းကတော့သူကပေါ့နော် episodic migraine with visual oral လေးသူရှိတယ်ဒါပေမဲ့အဲ့ဒီ migraine ကသူပြောင်းနေတာတော်တော်လေးနှစ်ပေါင်းတော်တော်ကြာနေပြီဒီတစ်ခေါက်ခေါင်းကိုက်တာကတော့သူကဒီဝိမရင်နဲ့သူမျက်စိထဲမှာပေါ့နော်ဒီstimulation လေးရလိုက်တတ်တယ်ပြီးတဲ့အခါကျတော့မှ right posterior temporal headache သူရလာတယ်အဲ့ဒီခေါင်းကိုက်တာကသူ naproxen တို့ sumatriptan တို့တောက်ကြည့်ပေမဲ့လို့လေအဲ့ဒီ headache ကမသက်သာဘူး headache ကို neck pain ကိုသူတောက်လျှောက်ရနေတယ်စမ်းကြည့်လိုက်တဲ့အခါကျတော့ right sided ptosis နဲ့ meiosis လေးရှိတယ် MRI brain ကျတော့ normal ပဲအဲ့တော့ MRI head and neck လေးလုပ်ကြည့်လိုက်တဲ့အခါကျတော့သူက right internal carotid artery dissection လေးရှိပြီးတော့ intramural hematoma လေးရှိနေတာကိုတွေ့ရတယ်။ဒါကဘာကိုပြလဲဆိုလို့ရှိရင် headache attributed to injury to head and neck ကြောင့်မလို့ခေါင်းကိုက်တဲ့ဟာကိုပြပါတယ်။ Now case number 9 28နှစ်အမျိုးသမီး ကလေးတယောက်ရှိတယ်သူကလွန်ခဲ့တဲ့၄ဘက်ကစပြီးတော့ occipitalနဲ့ vertical headache လေးရလာတယ်ဒီလာမပြခင်၄ရက်မှာတော့သူက blur vision နဲ့ double vision လေးရတယ်အဲ့ double vision က left side ကိုကြည့်လိုက်တဲ့အခါမှာပိုပြီးဆိုးတာကိုတွေ့ရတယ်လွန်ခဲ့တဲ့6လကစပြီးတော့သူ oxypill တောက်နေတယ် BMI ကလည်း29ဆိုတော့များတယ်သူ fever တော့မရှိဘူးအရင်တော့လည်း past medical history လည်းဘာမှမရှိဘူးလို့ပြောတယ်စမ်းကြည့်လိုက်တော့ neck stiffness တော့မရှိဘူးဒါပေမဲ့ fundoscopy ကြည့်လိုက်တော့ bilateral papilledema လေးရှိနေတယ် external ocular examination လုပ်ကြည့်လိုက်တဲ့အခါကျတော့ left lateral rectus weakness လေးတွေ့ရတယ်တခြား examination တွေကတော့ normal ပဲအဲ့တော့ချက်စိတ်ဆွေးတို့ NECT neck head တွေလုပ်ကြည့်လိုက်တော့ normal ပဲ blood test လုပ်ကြည့်လိုက်တဲ့အခါကျတော့ channel test တွေက normal ပဲဒါပေမဲ့လို့ဒီတိုင်းမှာကပုံမှန်ထက်4ဆလောက်တက်နေတယ်အဲ့တော့ MRV brain ရိုက်ကြည့်လိုက်တယ်ဘာတွေ့လဲဆိုလို့ရှိရင်ဒီ left transverse sinus နဲ့ left sigmoid sinus မှာ thrombosis ဖြစ်နေတာကိုတွေ့ရတယ်ဒါဒီ cerebral venous sinus thrombosis ပေါ့နော်ဒီ case ကဒါကဘာကိုပြလဲဆိုလို့ရှိရင် headache attributed to intracranial vascular disorder ဆိုတာကိုပြပါတယ်နောက်ဆုံး case လေးတစ်ခုကတော့28နှစ်အမျိုးသားပေါ့နော်သူကလွန်ခဲ့တဲ့6ပတ်ကစပြီးတော့ခေါင်းကိုက်တာကိုတတိထားမိတယ်အစတော့အဲ့ခေါင်းကိုက်တာကibuprofen လေးတောင်းလိုက်လို့ရှင်သက်သာလာတယ်ဒါပေမဲ့နောက်ပိုင်းမှာ frequency တွေပိုစိတ်လာတယ် severity ကပိုဆိုးလာတယ်အဲ့အတွက်ကြောင့်သူ ibuprofen တို့ naproxen တို့ခဏခဏတောက်လာရတယ်ဒီလာမပြခင်တစ်ပတ်လောက်မှာတော့သူကခေါင်းကိုက်တာဒီ naproxen တို့ဘာလို့တောက်လဲမသက်သာတော့ဘူး persistent ဖြစ်လာတယ်အဲ့အတွက်ကြောင့်လို့သူလာပြတယ်အဲ့တော့သူမှဖျားလားမဖျားလားဆိုတာတော့သူတတိမထားမိဘူးဒါပေမဲ့လို့သူ nausea လေးရှိတယ် appetite ကျတာလေးရှိတယ်6ပတ်အတွင်းမှာ 2 kg လောက်သူ weight ကျသွားတာသူတတိထားမိတယ် examination လုပ်ကြည့်လိုက်တဲ့အခါကျတော့ bilateral lateral rectus weakness နဲ့ diplopia on horizontal eye pursuit လေးတွေ့ရတယ် motor weakness တွေတော့မရှိဘူး meningeal irritation sign တွေမရှိဘူး temperature normal ပဲတခြား systemic examination တွေကတော့လည်း normal ပဲတော့သူချက်စိတ်ဆွေးရိုက်ကြည့်လိုက်တော့ miliary TV လေးကိုတွေ့ရတယ် MRI brain with contrast ရိုက်ကြည့်လိုက်တော့ CNS tuberculosis တွေအများကြီးတွေ့ရတယ်ပေါ့နော်အဲ့တော့ဒါက example of the headache attributed to infection ဆိုတဲ့ဟာကိုပြတာပါအဲ့တော့လူနာတယောက်ကခေါင်းကိုက်တာနဲ့လာပြီဆိုလို့ရှိရင်ဒီသူ့ခေါင်းကိုက်တာဒီ potentially life threatening headache ဖြစ်နေမလားဆိုတဲ့ဟာကိုကျမတို့က reflex တွေကိုကြည့်ဖို့လိုပါတယ်အတူကောက်အားဖြင့် snooze ဆိုပြီးတော့သတ်မှတ်လို့ရပါတယ်ပထမတစ်လုံးကတော့ systemic symptoms တွေပါနော် fever chills တွေရှိသလား rash myalgia တွေ night sweats တွေ weight loss တွေရှိတယ်ဆိုလို့ရှိရင်တော့ကျမတို့သတိထားပါမယ်နောက် secondary risk factors တွေရှိသလားပေါ့အဲ့ဒါတွေကတော့ systemic malignancy ရှိသလား HIV positive လား pregnancy or postpartum period လားဒါတွေဆိုလို့ရှိရင်တော့လေဒါဒီ life threatening headache ဖြစ်မယ်ဆိုတဲ့ဟာကိုဂရုစိုက်ရပါမယ်နောက် neurologic symptoms အနေနဲ့ဆိုလို့ရှိရင်တော့ change in mental status or level of consciousness တွေရဲ့ diplopia abnormal cranial nerve function တွေ pulsatile tinnitus တွေ loss of sensation weakness ataxia တွေရှိမယ် history of seizure collapse loss of consciousness တွေရှိမယ်ဆိုလို့ရှိရင်လည်းကျမတို့ဒါဒီသတိထားရပါမယ် now OR or present onset ပေါ့နော် sudden or first ever headache ဖြစ်မယ် severe or worst headache of the life ဖြစ်မယ် tender clap headache ဆိုလို့ရှိရင်တော့ကျမတို့သတိထားရပါမယ်နောက် O တစ်လုံးကတော့ older ပါဒီ headache ကအသက်50နဲ့အထက်မှာစပြီးဖြစ်လာတာဆိုလို့ရှိရင်တော့လေကျမတို့သတိထားဥပမာဆိုလို့ရှိရင် cancer arthritis လိုဟာမျိုးတွေဖြစ်နိုင်ပါတယ်အဲဒါဆိုလို့ရှိရင် vision impairment တွေသူရနိုင်ပါတယ်နောက် PR ကျတော့ pattern change ပါနော် progressive headache ပေါ့နော်ကျွန်မရှိမှပြောခဲ့တဲ့ case လိုပဲပေါ့နော် daily ဖြစ်လာတဲ့ continuous ဖြစ်လာတဲ့ဟာမျိုး precipitated by vulvar maneuver ချောင်းဆိုးတာနှာချီတာပေါ့ strain လုပ်တဲ့အချိန်မှာပိုပြီးကောင်းကိုက်တယ်ဆိုတာ increase ICP ဆိုတဲ့ဟာသတိထားပါမယ်နောက် postural aggravation ရှိတယ်ဆိုလို့ရှိရင်လည်းသတိထားမယ် fundoscope ကြည့်လိုက်လို့ papilledema ရှိတယ်ဆိုလို့ရှိရင်တော့လည်းဒါဒီ life threatening headache ဖြစ်နိုင်တယ်ဆိုတဲ့ဟာကိုကျမတို့သတိပြုဖို့လိုပါမယ် ဒါတော့ကျွန်မ presentation ရဲ့ key messages လေးပါ migraine is the most common disabling primary headache globally ပါ attacks typically present with unilateral throbbing headache and associated symptoms including nausea, multisensory hypersensitivity and mild fatigue. The diverse symptomatology highlights complexity of migraine as a whole nervous system disorder involving somatosensory, autonomic, endocrine, and the arousal networks. First step in diagnosis of a patient presenting with headache is to differentiate between a benign headache disorder, that is primary headache, and a serious underlying conditions, that is secondary headache disorder. Potentially life-threatening headache can be identified by eliciting red flags, that is SNOOP, during patient's history and examination. Thank you for your kind attention.
Thank you, Jala. Thank you very much for your very informative presentation on different types of migraine and other forms of headache mimicking migraine. As the question and answer section will be after all the presentations, may I hand over the symposium to my co-chair, Professor Wimende.
Thank you, Mama. So, it is indeed great honor and great pleasure to me to be co-chairing the scientific talk about updates in migraine management 2020. I would like to invite the second eminent speaker, Professor Siminyai. She's a senior consultant neurologist. She passed MBBS in 1996 in University of Medicine 1, Yangon, and she got through the MEGST Internal Medicine in 2002, MRCP UK in 2007, FRCP is Deborah in 2011, and she got the Doctor of Medicine Neurology in 2012, and fellowships in the neurophysiology, EEG, and clinical neurophysiology. So she is a professor from neurology department in 2017.
Ask Professor
and now,
Innocent to stop sharing his slides.
now she is working in the as a senior consultant neurologist in Ishara Hospitals. Also, she has a very good experience in the migraine attacks, and she is also a sufferer of the migraine, so she can talk very nicely and very comprehensively. Thank you. So please say.
Thank you. Thank you, Mama, for your kind presentation, kind introduction, and good afternoon, everybody. And I would like to also thank Prof. Micho, Prof. Wimende, and the Dr. Sharma for being with us, and also to Prof. Asan to make this event, and also to Zydus scheduler to make this webinar CME to a success. My talk will be on the practical tips. Predicated acute treatment of the migraine. Okay. This is the contents of my talk, or diagnosis, pathophysiology of migraine, and management of the acute attack, pharmacological and non-pharmacological approach. As Prof. Asan has mentioned in her presentation, that burden of the migraine is quite huge. So for the sake of the time, I won't repeat these slides. So, and also the diagnosis of migraine is very important before we give the treatment. We have to make sure that the patient has migraine, because in examination we will not find any abnormal finding neurologically, and for every case who come to our clinic or to the hospital, there is no indication to do imaging all the time. So we have to, the first thing is we need to make sure that the patient doesn't have the red flags, which can be a synergist cause for the light threatening as well as the sight threatening cause of the headache. And the second thing is that we have to differentiate from the other cause of the migraine, migraine mimic, which Prof. Asen has nicely and comprehensively explained in her talk. Basically, we use the international classification of the headache disorder criteria for the migraine for our diagnosis. So after we diagnose the patient has a migraine, regarding the acute treatment, because my focus of my talk will be on the acute treatment. So in acute treatment, it will be pharmacological therapy and non-pharmacological therapy. In pharmacological therapy, it will include the acetaminophen, paracetamol, and NSAIDs, triptans, emetics, and newer drugs. In non-pharmacological therapy, it will include neuromodulation therapy and nerve block. We have to, if we know a little bit about the pathophysiology of the migraine attack, then we will know how the drugs are effective when we use in the acute attack of the migraine. So as Prof. Asen has mentioned in her presentation, that conventionally in migraine, we divide it into the premonitory phase, aura phase, and headache phase. So this is a brief diagram of the hypothesized sequence of events in migraine. And in this, as Prof. Asen has mentioned in her slides, that when we have the modulating factors like drugs, environment, hormones, and genes, or the metabolic causes, it triggers the disturbance of the cortical or brainstem excitability in our brain, causing cortical waves abnormal. We call cortical spreading depression, and in which case we have the cerebral blood flow changes and as well as associated calcium channel changes, causing aura, visual, for example, visual, sensory, and cognitive. So this is, we call it aura phase. Because of that, the changes in the cortical waves, and as well as because of the disturbances in the cortex brainstem excitability, there will be trigeminal nucleus caudalis, dorsolateral pons, where the brainstem activation happens, and as well as the central sensitization. Because of this, there will be activation of the pain receptors, causing release of the nociceptive messengers and vascular and metabolic changes, and release of the vasoactive peptides like CGRP and the neurokinins, etc., causing neurogenic inflammation, vasodilation, and protein extravasation. In that case, the patient will have the pain, so we call it the headache phase. And as well as in that case, because of the brainstem activation, there will be the sensory sensitivity, and the patient will have photo and phonophobia, and cutaneous allodynia, and nausea, vertigo symptoms can happen. So let's see how the individual drugs are effective in the migraine. Firstly, paracetamol and the NSAIDs. So they block the pathway of the inflammatory factors, and also by blocking this pathway, there will be less fluid leakage and less inflammation, and it also blocks the central and peripheral pain center. So actually, paracetamol is widely used, and it is very effective primarily for the attacks of the mild or moderate severity of the attack. And NSAIDs is also the good starting point for the acute migraine treatment, in which ibuprofen, naproxen, acetylsalicylic, we call aspirin, and diclofenac potassium, they all have double-blind randomized controlled trial evidence for the efficacy. And aspirin also has relatively rapid absorption and the intermediate half-life of 5 to 6 hours. So this is quite effective in the migraine. And effervescent aspirin has faster absorption than regular tablets. In contrast to naproxen, which has slower absorption but much longer half-life, so that the patient can have the pain-free interval for more longer duration. And ibuprofen and diclofenac potassium, they also have the very rapid absorption, so it is very also useful and effective in the treatment of the migraine. So this is a summary of the acetaminophen and the NSAIDs. And here, as we can see here, the number need to treat for 2-hour headache relief and 2-hour pain-free is very good in the aspirin group, and as well as in the ibuprofen, which is more or less similar, and as well as in the diclofenac potassium, both the powder form and tablet form, while naproxen has the longer half-life, which is also good for the sustained relief. And after paracetamol and NSAIDs, we will go to triptans. So how triptan works, mode of action. Triptans are selective 5-hydroxytryptamine receptor agonists with high affinity for 5-HT1B and 5-HT1D receptors. So stimulation of the 5-HT1B receptors on smooth muscle cells of the blood vessels cause cranial vasoconstriction, by which the patient will have the pain relief. And again, 5-HT1D receptors, which lie on the perivascular trigeminal nerve terminus and in the dorsal horn. So stimulation of these receptors will block the release of the vasoactive peptides from trigeminal neurons and as well as neurotransmitters in the dorsal horn, which convey the nociceptive information to the thalamus and to the pain center. So this cartoon diagram shows how triptans work. So this is the by blocking this blood vessel, vasoconstriction of the blood vessel by stimulation of the 5-HT1 receptor and the again 5-HT1D receptor, and also block the cause the decreased excitation to the trigeminal cervical plexus, by which mean triptan can effectively reduce pain in the migraine. Currently, 7 triptans are available in oral form and all have good evidence for efficacy in acute migraine therapy. There are also non-oral forms like subcutaneous injection, nasal spray, and parenteral form. Although all triptans share a relatively similar molecular structure, individual patients may respond to different triptans in different ways, both in terms of effectiveness for pain relief and side effects. This table summarizes the available triptans, sumatriptan, somitriptan, rizatriptan, naratriptan, almotriptan, alitriptan, frovatriptan, and their half-life, bioavailability, and elimination route. Because of the time, I won't go in detail. Okay, so effects of triptans. When we compare, we have the many studies in comparison between the triptans and placebo. All 7 triptans are superior to placebo, and the response of individuals to specific acute drug is unpredictable. If the patient does not respond well to one triptan, we can try other triptans because in subsequent attacks, because different people can respond differently to different types of the triptans. So if one triptan is fail, and we can choose the another triptan. But whenever we should use triptans, the safety is our concern. So regarding the cardiovascular safety, all symptoms can be associated with triptan sensation, in which the patient can have burning, tingling, or tightness in the face, neck, limbs, or chest. And in some people, it's just very subtle, but in some patients, it can be sometimes quite alarming. However, in most cases, it is not associated with the ECG changes or other evidence of decreased myocardial perfusion. And safety in the pregnancy and the breastfeeding, the use of triptans during pregnancy and as well as during breastfeeding, the data is quite limited because there are no well-controlled studies of triptans in these cases. Regarding the interaction, we have to be careful when we use triptans in patients who are taking it monoamine oxidase inhibitors within or so we have to use after we stop 2 weeks, we stop MAOI. Only 2 weeks after we stop MAOI. Then also there is potential risk of serotonin syndrome if we give triptans in patients who are also taking SSRI, serotonin reuptake inhibitors. In our Myanmar market, there are 2 available triptans in Myanmar, and only tablet forms are available. They are sumatriptan and zolmitriptan. Sumatriptan, we have two brands. There's the sumatonin and triptan. Now zolmitriptan, it is Migo. Regarding the zolmitriptan, it is available as tablet and in other countries as nasal spray as well. The good point about zolmitriptan is it is rapidly absorbed and also reach peak plasma level in 2 to 4 hours. So with good level can be maintained up to 6 hours. But zolmitriptan should not be used in uncontrolled hypertension, coronary artery disease, arrhythmia, for example, like WBW syndrome, and also who are taking MAOI inhibitor. And also, zolmitriptan is contraindicated in patients who are currently taking argotamine or another triptan. When we compare there are a few studies comparing zolmitriptan and sumatriptan. According to these studies, zolmitriptan offers good, better bioavailability, and it has both dual central and peripheral action. And 2.5 milligram dose was significantly more effective than 50 milligram dose of sumatriptan in terms of headache response at 2 to 4 hours. And it is significantly more likely to have pain relief over 24 hours than those taking sumatriptan. After triptans, there are other effective medications like antiemetics, especially in patients who have very severe nausea and vomiting, metoclopramide, cloproprazine, and sometimes lidocaine intranasal is of some help. And we also have newer drugs. CGRP agonists are emerging recently, and in 2019, there are 3 classes of CGRP targeted migraine therapy with proven efficacy, and also it is FDA approved since 1918 and in some 2018 and 2019. We have 3 categories. The CGRP agonists can be used, some can be used in the acute attack and some can be as the preventive therapy. Small molecule CGRP agonists, like for example, abugipant, vazigipan, and monoclonal antibody binding to CGRP. In this group, galcanzumab is like twisting tongue, right? To name those, to call those names, and aptinizumab. And the third category is monoclonal antibodies binding to the CGRP receptor, arinumab, which can be also used for the preventive therapy. So this is a diagram showing how that the CGRP works through this pathway. They block peptide release, CGRP peptide, so that and CGRP neurokinins triggered by the nerve signals, and also they decrease the excitation of the trigeminal nerve. Here's some practical tips. Whenever we have the migraine patient, we have to think about, when we treat those patients, okay, we have to think about whether the patient will be beneficial from acute treatment or whether they will also need a prophylactic treatment. As special consideration should be done in women and girls with migraine because of some issue, especially for the preventive therapy we use, the drugs we use can be contraindicated in the reproductive age. So the goals, we must set the goals in migraine management. So the first important thing is that we have to treat attacks very rapidly and consistently without recurrence, and we must have minimal or no adverse effects. And we have to minimize the use of backup and rescue medication like steroid therapy and the other therapies, including the opioids. And it must be cost effective for overall management, and we must restore the patient's ability to function. Those are very important goals we must set whenever we see the patient with migraine. And another important thing is the first step in the management of migraine we need to identify and manage migraine triggers like sleep deprivation, alcohol, dehydration, and etc. And without removal of the that triggers, and that migraine management cannot be successful. And second step is we need to identify the possible contributing to headaches from medication overuse. Sometimes when the patient, especially in the chronic migraine case, we need to differentiate whether this is the headache due to the medication overuse, or it is the chronic migraine, or whether they have the overlap. And in the management approach, two management approaches, the universally accepted. One is step care approach, and second is the stratified approach. In step care approach, in step 1, we start with over-the-counter analgesics like paracetamol and NSAIDs. And on step 2, if the patient doesn't respond, and we add the triptan, as we give the triptan. And in step 3, we use the combination therapy and plus or minus and antiemetics depending on the patient's symptoms. In stratified care, we give the acute medication depending on the disability and degree of the severity caused by migraine. So there is some evidence that stratified care approaches better than the step care approach, and patients with greater disability are started on triptan initially. So in this approach, if the severity is just mild to moderate, we start with the simple analgesics, and if not responded, we can use combination analgesics and caffeine combination, which we do have that combination tablets in our market as well. And if it is there is no adequate response, then we will manage this patient as a severe migraine. So in severe migraine, we give triptan. We start with the triptan first, and if not, we can add with the nasal spray and other rescue therapy. And if the patients have associated nausea and vomiting, we can add an emetic either in patient with a mild to moderate or in patient with a severe. So this is a stratified approach. So what about the combination therapy? As I've told earlier in the previous slide, analgesic and caffeine combination are better than one of its component alone in some studies. And as well as triptan and then the NSAID combination, they have good evidence that combining sumatriptan and naproxen or sumatriptan and the NSAID they do have a higher 2-hour headache relief than the single therapy alone. But combination analgesics with opiates we do not advise to use routinely because of that is the medication. We are afraid of resultant medication overuse headache. So that is the ANA recommendation for acute treatment, that acetaminophen and the NSAIDs, they have great level of evidence. Then triptans and argos are also level of evidence. Then antiemetics, B evidence, and the nerve block steroids, they are not rated. So, but we need to take precaution when we use the triptans and NSAIDs to avoid medication overuse headache, because it results from excessive use of analgesics and triptans for migraine. So triptan should not be used for more than or equal to 10 days per month on regular basis. And paracetamol and NSAIDs, we should not give more than 15 days per month. And as well as most guidelines advise that codeine and other opiates should not be used routinely to avoid that medication overuse headache. So after pharmacological therapy, I will go to the non-pharmacological therapy. Several neuromodulation devices have emerged as being effective for both acute and preventive migraine treatment. So how does it work? Let's see. Neuromodulation, they block the, as this cartoon shows that we have the target for neuromodulation are the cortex, thalamus, hypothalamus, and the pain transmission, which the loop, which happens like a loop in the trigeminal cervical complex, and as well as to the upper cervical nerves. Those are the site we target for the neuromodulation. So what are the neuromodulation therapy available? Transcutaneous stimulation, for example, like the transcutaneous occipital nerve stimulation, and as well as supraorbital transcutaneous stimulation, and non-invasive vagus nerve stimulation. And since 2018, FDA approved in the States for the acute treatment of the migraine, and as well as external trigeminal nerve stimulation has been approved since 2017 by FDA. And transmagnetic stimulation is also one of the important neuromodulation therapy, and since 2014, and for the both acute and prophylactic treatment of the migraine attack when conventional therapy, pharmacological therapy fail. So nerve block is also another option of the non-pharmacological treatment, where we can give the extracranial nerve blocks and trigger point injections. And there is supportive consensus statement from the American Headache Society that these options are also effective. The targeted nerves usually include supraorbital, supratrochlear, greater and lesser occipital, auricular temporal nerves, and the sphenopalatine ganglia, depending on the severity of the migraine and the site of the pain. The infiltration of the local anesthetic is also very useful for both acute and preventive treatment of the migraine. The meta-analysis also showed that compared with the control intervention, greater occipital nerve block can reduce the number of the headache days and medication consumption. To summarize the facts I have already discussed, we really need to educate the migraine sufferers to participate in their own management and to decide whether they would prefer to go for the step care approach or stratified approach. And abortive therapy should be used as early as possible after the onset of symptoms, because they are more effective if given early in the course of the headache, before all the peptides of the neurokinase of the CGRP are released to a highest level, where the acute therapy, the drug therapy cannot block all these chemical mediators once it is released to a full extent. So this is to treat as early as possible is very important. And NSAID are very useful first-line treatment for mild to moderate migraine, where triptans are first-line treatment for moderate to severe migraine. And the choice of triptan should be individualized based on patient's migraine characteristics and also on the route of administration, pharmacokinetics, and the cost. So depending on the availability and the preference of the patients, and as well as the pain severity of the migraine, the triptan administration should be individualized. And the frequency and severity of the migraine attacks should be monitored to assess whether patient need prophylactic medication and also to avoid medication overuse headache. CGRP antagonists have emerging roles for the acute and preventive treatment of the migraine, and non-invasive and invasive neuromodulation approaches are also give us a promise in both acute and preventive therapies, although further studies are needed to define appropriate candidates for those therapy and optimum protocol for their use. In our country, we don't have experience of using CGRP antagonists because it's not in our market, and as well as we don't have neuromodulation therapy so far. And with that, I would like to conclude my talk, and thank you so much for your kind attention.
Thank you, Professor Singh. And you present a very interesting and complete lectures on the practical tips of the acute treatments of migraine. Now, being of the least, I would like to call third speaker. I would like to invite Dr. Arvind Sharma, head of the Department of the Neurology, stroke specialist, Zydus Hospital, Myanmar, Denmark. He is also the honorary associate professor of neurology at Mount Denmark. He got the MD. Hello? Yeah. Sorry. He got MGGM Neurology from PGI, Canberra, India, and he also a clinical fellowship in stroke, University of Alberta, Canada, and also fellowship in cerebrovascular ultrasonography and UH, Singapore. And also she has a ASN certified neurosonography in USA. Now he will discuss about the landscape of migraine management and treatment.
Thank you. Thank you, Chair Professor Winman Ted. And thank you, Chair Professor Minmin Cho, for inviting me for this talk. Was very excited about this. And I would definitely give a very, very lucid and very elaborative talks by all the two previous speakers, Sinmin and Professor I. Sain. And I would thank Zydus to invite me for this talk, and I'll try to share my slides now. So I have to minimize this.
Yeah, sir, you can minimize the browser.
The browser, right? I can make
Yes.
it. Wait a minute. I'm not able to. Yeah, this one. I have to go down. I have to go on the right top, right?
Yeah, right top, sir. Further top. Further top. Further top.
Okay.
Further top. Yes,
Yeah.
yes, yes,
Okay.
yes, yes.
Thank you very much.
Yes.
So
yes.
Once you are able to see my slides, then it's okay.
Yeah.
Are you able to
we
see?
can. Yeah, we can see your slides, so you're good to go.
So, wonderful presentation by all the two speakers, and almost most of the things are covered. I'll take you to the latest treatment which are available. And before that, I proceed further. I would like to brief something about the migraine or the primary headaches, especially the migraine. It is a lifestyle disease. We all know about it. So the best thing is the primary prevention by doing the lifestyle modification. As you can see, WHO has labeled it to the quadriplegia, equivalent to the quadriplegia and dementia. And the way the disabling primary headache disorder, you can see the impact. It is the second highest cause of year lost due to disability. And even if you see the US prison, the most absentees was because of the migraine. The second highest contributor to neurological disease after stroke, and it affects 2% of the population across the world. The way it is goes across the migraine, as all my dignitaries there on the chair who are experienced, they know there is a bimodal peak of the migraine is always there. The boy, it start at the age of 8 to 10 years, and for the girl it start at a menarche if they are having the migraine type of headache. And as this is the only disease which decrease with the age if you do a good lifestyle modification in your life, and if you are on prophylaxis or on treatment. And as you age, you again can have the similar kind of headaches as a second peak. So it is near about between the most reproductive age group, it is highest, and it affects your your work environment also. So these are the types of migraine already been discussed. With aura is classical, without aura is common. Family hemiplegic migraine, migraine in women, will touch upon it. What are the treatment different from the other migraines? And cerebellum and migraine, we all know how white matter hyperintensities are there in cerebellum of migraine. The International Headache Society criteria, as you all are aware of it, and both the speakers have demonstrated so well about it. So the one is at least 5 attacks with the B to D criteria, untreated, unsuccessfully 4 to 72 years. It should be unilateral in location, but we all know that it can be bilateral. It can be bilateral frontal, it can be bilateral temporal. It doesn't always present like books. And many of the sinuses, the sinusitis, they are treated not treated, and they are considered as sinusitis, moderate to severe pain aggravated by causing avoidance of the routine activity. And during headache, at least one, like photophobia, phonophobia, not getting better with the another diagnosis. The migraine with aura, 2 attacks, and they should fulfill the aura criteria, either visual. Visual, you all know it is the most common, that is 99% of the auras are visual. Others are there, but they are not sensory. People many times complains that they have a headache at the backside and it is radiating to their arm. And many a times it is diagnosed as a cervical spondylosis, but they have typical throbbing, they have typical pulsating headaches, and they are considered as a cervical radiculopathy. So it is very important to know the clinical features which you are dealing with, like the sensory symptoms, speech, motor. Retinal migraine is also a very unique thing which we should know about. At least 2 of the following are there. The visual aura spreads gradually over greater than 5 minutes. It can be 5 to 60 minutes. Even we have seen auras to persist for 2 to 3 hours. And they are sometimes before the headache, and headache presents after that. And it can be during the headache also. So how the migraine pathophysiology occur, very nicely demonstrated by the last speaker, but I'll just take you to the phases, because the treatment depends on a lot on that. Early you treat, you can stop the attack and you can abort the attack in the initial phase when you're having at the level of the premonitory phase. And if the subject knows or the patient knows about his headache. So it is not where the abortive medications, that is why the pathophysiology is very important. The abortive medication don't have much effect when they are taken at the peak of the headache, and then you have to give the another medication. So the phase 1 is fatigue, mood change, food cravings, muscle tenderness, which are many times diagnosed as fibromyalgias, photophobia, and yawning. And there is an interplay between the homeostasis and the onset of migraine. So it can be that premonitory symptoms can be 1 or 2 days prior, and they are considered as vague symptoms or symptoms of malaise and some viral symptoms. So if you go in the phase 1, if you see on this bold technique of the fMRI, which is there on the scan, that is PET scan overlap with that, is the activation is the right posterior and the lateral region of the hypothalamus, which was shown in the anatomical location by the last speaker, and the adjacent right midbrain ventral tegmentum. These are the areas activated because of the trigeminal vascular complex. We'll deal it further. So this is how the mechanism goes in the phase 1 premonitory, that is meningeal nociceptors, multiple parasympathetic signals to the superior salivatory nucleus, all have a value, right? Then it goes to the sphenopentyl ganglion. I tell you, I was part of the trial of the sphenopentyl ganglion used in stroke for the treatment. It was a trial done in India when I was in PGI Chandigarh. We have seen patients who are having migraine, when they were giving stimulation for the sphenopentyl ganglion, their migraine improved when they were treated with the stroke. They were not having the migraine again when they were treated for the stroke with the SPG stimulation. The activation of the meningeal receptors of the trigeminal vascular pathway, it is all which is latest vascular pathophysiology, where the trigeminal vascular complex, where all the inflammatory markers, and there the target is for the treatment part, where the main concept of the treatment is to treat such patients. And there is a vasoconstriction and vasodilatation theory, and where there the serotonin comes in the picture. When the serotonin increase, there is a vasoconstriction, and when the serotonin level goes down, there is a vasodilatation and the release of the inflammatory markers and causing the headache. And this goes in the circadial phase and the high and low thresholds of the nociceptor signals. So if you go on the phase 2 of the aura, we already discussed, they can be in the 1/3 of, when most common is the visual aura. And this is how from the occipital area, as been demonstrated on the fMRI and the PET, it is a slow propagating 2 to 6 millimeters per minute propagating wave of depolarization, followed by the inhibition of the cortical activity up to 30 minutes, coinciding with the initiation and progression of the aura symptoms, and associated with the wave of hyperemia, and then there is a cortical oligemia, just like a vasoconstriction. So there can be two theories for the phase 3 of headache. There is a nociceptive neurons innervating dura mater are stimulated, and there is a release of the vasoactive peptide, where comes the calcitonin gene receptor peptide, where the antagonist has been developed as a latest therapy, which we're going to discuss, and the PACAP38 peptide, and the signaling along the trigeminal vascular pathway. Or there is a cortical spreading depression for the aura, release of glutamate, potassium, and CGRP, and diffuse towards the activated meningeal nociceptors. And here comes the concept of the peripheral sensitization and the central sensitization. And this diagram already shown by the previous speaker, so I'll not go into detail of it. I'll go to the summary of it. The central sensitization occur, then the allodynia occurs. People complain of even you touch their head, they feel a severe amount of pain. So this is what the summary which we have discussed. The abnormal cortical activity, hyperexcitable brain, increased calcium, decreased glutamate and magnesium, cortical spreading depression causing the aura, activate and sensitize the trigeminal-vascular system, which is the most important, where all the mast cells and other inflammatory markers get activated, and there is a vasodilatation and neurogenic inflammation. And this is how there is activation in the brainstem, which we shown in the PET scan to you, and central sensitization causing the head pain. Any headache of migraine which occurs has a natural tendency. When these drugs were not there in the form of acute therapy or the prophylactic therapy, you have seen people resting down while the acute attack of migraine. There is aura or not aura. It is a prodrome, aura or without aura, mild pain to moderate pain, and subsequently in a day or two, maximum 3 days, that headache subsides. That is what is a normal physiological way of any classical phase of migraine is, with common or classical migraine. We are not discussing here about the status migrainosus. So status, they doesn't improve by their own. There the treatment is needed in different forms. So these are the different form of headaches which we should know. There is an ice cream headache, which is at the center. Sinusitis headache, you know the location. But we should know that patient doesn't present like a book. They can have an overlap of these headaches. But migraine and cluster, it is very clear there is a reddening of the eye. There is lacrimation, nasal stuffiness for the cluster headache. Tension headache, very well described with the previous speaker. You feel a heaviness of that. And neuralgias are neuralgias. They are current and electric shock-like. But there are overlap of symptoms whenever there are headaches. These are all primary headaches, which we should know, and we should take the history. Cough-induced headaches, postcoital headaches, these are all headaches which has to be known, that has to be differentiated from the migraine. And this differential is very important. We all burn our fingers when we are treating migraine. So when you treat a migraine, you should know that you should have one basic imaging done if there is a change in the character of headache after there is a symptom relief with your prophylaxis or your treatment. Because if you don't do and their character change and they are not effective on the treatment which they were before, they can present. I have shown you, this is one of my patients with the frontal lobe meningioma, and there are meningiomas at the other end also. I have seen in my practice, and all the dignitaries are on the dais, may have seen many resembling frontal lobe meningiomas are the most resembling to the migraine. So whenever you find your patient who are doing very well on headache and there is a character change, I'll give you a very good example. I was treating one of a young chap for migraine. He went for US for the studies, came back with a very different headache. It was a long flight. He had a character change of the headache and a very severe headache with vomiting. So we thought it going to be because he is coming from a long flight. He has not moved in the flight. He may be having a CVT. And we found a big frontal lobe glioma in that young chap. So that is what is very important when you are dealing for the red flags which has been shown. And burden of the migraine, we all know it has overall impact of the migraine disorder is huge. If you can see in the form of overall impact on all the other lines, blue, red, the impact on the family life, disease cost, interictal burden, impact on the school activities, and even you have seen many mother and many wife, they are saying that we call it now not as a wife headache, we call it the spouse headache. If it become chronic, it becomes very difficult to treat. And there are a lot of abuses in the form of medicine use, where they have been shown very nicely that more than 15 days of the analgesic use, and we find such patients having a huge burden where the mother is saying that I never had been in a loud voice with my kids, but migraine is like this, where you change your personality if they are not controlled. So this is what the chronic migraine epidemiology and outcome has shown. There is a reduced participation in the family activity, worried about the long-term financial security because they are not doing well, and their quality of work at the workplace decreases. And you can see the interplay with the episodic migraine and the chronic migraine. I'll show you how the migraine transforms in different forms and it becomes a chronic migraine, how you can lose in your all the work activities and the home activities when you're seeing. So how you can lift the burden of the migraine by managing the risk factors, that is the most important thing. You have a stressful lifestyle. We always talk about stress, right? So stress at a certain amount of level, when it is pulled up, and if it is dropped there, it doesn't affect your body. But stress, if you keep on taking that and pull with that for weeks, then definitely it affects your body and it affects your migraine. So sometimes many patients come and they ask you that, is it that stress is causing the migraine? You have to tell them it is an interplay in between. That if you have a migraine, you are not like others, that if you keep yourself empty stomach, you will not have headaches. People fast for 7 days, 8 days, but they don't have headaches. But you are a migraine, you have to keep, like you have not to keep empty stomach more than 4 hours. You have to sleep 6 to 8 hours. And stress aggravates that and it synchronizes to increase your headaches. So lifestyle and the non-pharmacological treatment, keeping a diary is fantastic. Which drug is effective for you and how it has got relief. It is the relaxation activity in the form of music. Have you managed your stress? So management and the diversification of the stress is also very important. Non-pharmacological treatment and the cognitive behavioral therapy is very important for such things. Then we'll talk about the preventive treatment like beta blockers, antiepileptic drugs, which are, and there is sometimes people are using a Google a lot and they are now Google Earth and they come to you talking about the antiepileptic drug. Oh, this is a drug for epilepsy. So then you have to tell them that the drugs which are used for one purpose can be used in neurology for different purpose. Then we'll talk about the new anti-CGRP injections and devices, and the triptans will already taken in the picture. We'll talk about something about it, how they can be effective and anti-nausea medication. So coming to the current landscape treatment for the current treatment and preventive therapies in migraine. So this is, to have a headache is a headache. This is when one of my cardiologists spoke to me, but to treat a headache is a bigger headache. So this is why I say that you are a cardiologist, don't treat a headache. Leave this headache to us as a neurologist. We'll take that headache as a headache and we'll treat them. And sometimes this joke comes very in a uniform way, that people take homeopathic, the different alternative medications, and they tell you that my home remedies like honey and other things like ginger, they are working more better than what you are prescribing the drug to me. So the AHS criteria for 2019, that 10 or more days per month for our GOD derivatives, triptans, and 15 more days per month if you are taking the analgesic. So how we decide on to give the preventive therapies. The different people have the different methods to use it. But if you see how you should give the preventive therapies and when you only use the abortive therapy. You don't use the prophylactic medication or the preventive medication. So these are the people where you offer it if it is 6 or more per month, but no disability, agreed. But 6 per month is a number of attacks where you need to give the prophylaxis. 4 or more, some disability that not able to attend the work, and 3 or more if they are severe. If I agree to 2 or more, and if it is severe, then also you can apply it as listen at consider it, but you can offer a treatment. 2 debilitating attacks will take at least 10 days of the life of that person for that month. So you can consider for 2 per month for moderate disability, you can consider the treatment. 3 with some disability and 4 or 5 with non-disability, that is for sure you should consider treatment in the form of preventive therapy. So, and here it comes the number of headaches per month. Then comes the how long the treatment should be advised in the form of preventive treatment. So this is a question by every patient comes to you that how long I have to take the treatment. So you have to tell them in a form of prophylaxis, 6 months to 1 year, you have to take the treatment. You cannot stop the treatment in between if you are getting all right and you don't have any headaches in between, because it can lead to rebound attacks after you leave the treatment. So treatment with efficacy in the migraine prevention, established efficacy is beta blocker in the form of propranolol, already discussed, triptans. Botulinum toxin is established efficacy, agreed, but it is not used in the form of the acute migraineurs or the migraine who are in the list of the preventive and the acute treatment. They are more in the chronic migraines where the central sensitization has occurred. There we have used the botulinum toxin. Probably effective antidepressant and beta blockers, there is always, if the migraine frequency is very high, then there is a overlay of psychological symptoms in the form of depression. You all have seen pseudo dementia kind of depression when there are amount of the number of attacks are more, that they don't remember things because of this headache. Possibly effective ACE inhibitors, angiotensin receptor antagonist, and antihistaminic. So if you go on a chart of the favor of the treatment and the favor placebo, and if you see all the treatment for the prevention to selection of the prophylactic medication should be tailored according to the patient preference, its characteristics, and the side effects. So it is very clear that those who are, if you go from the higher to lower down, if you see the topiramate, it is a wonderful drug, because people who are coming with the migraine to you, they, if it is any, will not go for any gender bias for their male or female. They put on a weight a lot with the anti-migraineurs, right? So the first thing they ask that last time I took the medication, I gained 5 to 10 kgs of weight with the medication. So topiramate is a very good drug, but we have to be very careful with the topiramate in the sense we have to ask the person to drink at least 2 to 3 liters of the water per day, minimum of 2 to 3 liters. If more, it's good, because topiramate is very notorious to cause renal stone, and if it is given in a cumulative dose of more than 100 milligram, I have seen 5 or 6 cases of angle closure glaucoma, which these side effects to be told very clearly. But if you see a young obese female, then you should always keep a differential of benign intracranial hypertension, which is a very close diagnosis to the migraine. You should always see the fundus of those people. Fundus is a part of headache examination when we do. It is an extended part. We have to do it to rule out any papilledema while we treating a migraine, because BIH, the benign intracranial hypertension, idiopathic intracranial hypertension, is a very close diagnosis. And sometimes you start a topiramate, they start improving, but the recurrence is there if it is a BIH because of the high pressure of the CSF if you stop that treatment. Valproate is a very good drug, but it is notorious because it causes tremors, it causes hair loss, it causes, in polycystic ovarian disease, you have to be very careful about the valproate, and it has multiple other side effects which we should know. So beta blocker, propranolol, we have to titrate according to the patient preference. Propranolol has to be taken care of the pulse. It is a very good drug where there is a lightheadedness and you find people are going in the form of, we label a name, migraine epilepsy, where you don't find on EEG anything and patient goes unconscious and suddenly get up when you call it as a neurocardiogenic syncope. Such beta, if you do HUTT and they have a migraine symptoms, the propranolol is a very good drug for such individuals, such characteristic of patients. Flunarizine, again, the weight gain is the main problem, but it is a wonderful drug which can be centrally calcium channel blocker, which can be used at the night. Serotonin antagonist, and the amitriptyline is a drug which I would like to tell you where there is a sleep is a problem. It is a wonderful drug, and it is one of the medication which is safe even in the pregnancy, where you can use it, because you have, most of them are of a category C drugs. You have to take care that you are not giving those drugs to them. But amitriptyline, you have to remember, if it is a second peak in the, when the age is more and they are elderly, you have to take care of urinary retention, constipation. These are the side effects, sometimes delirium in the patient who are with the age. So different drugs for different subset of patient. That is the beauty of so many drugs which are available for the prevention, where you can use them very judiciously, which drug to be given to which individual according to the patient characteristic. Now, use of the anti-CGRP therapies, which is latest, and I'm part of one of the trials which is irinizumab, and it is used once a month as a subcute, and they are coming with the oral. We'll discuss about the oral drug also. The role of the CRGP in the migraine pathophysiology, here that all pathophysiology which explained by the other two speakers, and I reinforce it, is important, because you see this flow chart. There is meninges, neurogenic inflammation, trigeminal ganglion, then there is a peripheral sensitization, trigeminal cervical complex, and sensitization. If you see the anti-CGRP therapies, they act two places. That is why the peripheral sensitization is gone and the neurogenic inflammation is gone. So this is how the anti-CGRP, the calcitonin gene receptor peptide, act, and they make a difference, and the doses which is being used is once a month. And these are the various trials done for all the anti-CGRP monoclonal antibodies. As they are Zumab, they are all monoclonal antibodies, and how they are made. If they are Zumab, they are made up from different origin. So that is why they are known as the prefix as Zumab, Numab. So if you see the arinumab is being used at our place also for the trial. It is being used in the Strive and the Arise. It is used as a 70 milligram for the subcutaneous dose once a month, and can be used till 140 milligram. And there is a very good response rate. The only thing is that it is in the form of injectable. It is used as a subcute. But if you use for once a month, and once a month you have a very good low headaches, and you don't have that lower threshold having a migraine and again, then there are fremanezumab, then there is galcanezumab and aptinezumab. These are the Zumab which are used in different doses. The fremanezumab is used 225 to 675 milligram, and aptinezumab from 100 to 300 milligram. They are very good in chronic migraine also. There are good amount of, among them the arinumab has come up as the top one, which is very effective for even in the chronic migraine with a 50% of the responder rate. But having said that, they are still in the pipeline. We need to see that how they respond for 2 years of therapy. No trial has gone to the phase 4. So when they come in the market, it's too early to say that the gold standard amitriptyline we all have used for so long is still effective, that using a once a month. That is the beauty of this, that it is used once a month. So you can, if you can make the patient or a migraine, a patient headache free, it is fantastic to use once a month. So anti-GRP monoclonal antibodies, if you see, in comparison to the placebo, they have definitely have a much improvement and a significant p-value a week after the first injection. And if you can see how much effective they are in the doses of 375 milligram and 120 and 240, you can see the headache reduction in the 3 months, how much effective these drugs are in improving the headache days with galantamine. So coming to the abortive, these were the all preventive therapies. Now coming to the abortive therapies, where the new medication like lasmiditan and other drugs have come. So here we will discuss the triptans and the ergots and the non-specific like ibuprofen and naproxen and paracetamol and the opioids. The only thing which I want to say about the ergots, we all have used ergots before triptans, and we have seen one major side effect with ergot. It has a lot of contraindication. We know that it can cause vasoconstriction, but the most important, that the migraineurs have a background headache, which is very annoying with ergots if it is there. So, and it remains for long. If you take a next dose also, the background headache remains. And we consider that it converted into a chronic daily headache or a chronic headaches it has been converted to. So for mild to moderate headache, already been discussed beautifully by my last speaker, by acetaminophen and other drugs. I'll not go into detail. For moderate to severe, definitely triptans are the choice. If you see all the triptans, how they are pain-free response at the 2 hours, all have shown odd ratio beautifully. Naratriptan, zolmitriptan, almotriptan, all have shown beautiful on this forest plot. You can see that how they are comparison to the placebo. They have shown a good results in the odds ratio. And if you see the treatment versus 24 hours, that was the 2 hours, which is important, how much the pain relief is there. And if you see the 24 hours pain-free response, the naratriptan and the zolmitriptan, they all fall in the same areas, with naratriptan showing the maximum result, and they show a very good result in the 24 hours free. If you see the number of number needed to treat with the zolmitriptan by the Cochrane review, high quality evidence for the oral zolmitriptan. I don't know about the Myanmar, but at our place we have oral zolmitriptan, we have a nasal puff, and we have a strip, and we have seen while like the benefit is very good in all the three forms. The nasal puff has only one side effect, that when you ask to take a nasal puff of zolmitriptan and they do a puff, and if they swallow, it is very bitter in taste. So that is what is lacking in the nasal puff. If they can make it sweet, then it is beautiful. But the strip, the dispersible tablet, they are beautiful because they don't feel the bitter taste, and they dissolve, and it has a first pass metabolism is gone. So you bypass that first pass metabolism, and they are absorbed orally, and it has a beautiful work. You can see the headache free in 15 minutes. And if you see the number needed to treat for the category, it is very less for zolmitriptan. And if you compare the zolmitriptan to sumatriptan with the percentage of headache response in 1 hour, zolmitriptan at 1 hour has definitely showed a much benefit than the sumatriptan in 1 to 4 hours. And in response 2 to 4 hours also, if you see the percentage wise, the low dose definitely has a much better outcome with zolmitriptan. And you all know about the where not to use the triptans, already been told by the last speaker very well. So overall result of this study concluded that zolmitriptan has a better efficacy as compared to sumatriptan, but it is individual patient categorization of a migraine is very important. But the way the triptans are given, it is also very important to give. And always remember, not 2 zolmitriptan of the maximum dose in 1 day, and not more than 5 in 1 week, which is very important while we are dosing the triptans, not more than 10 per month, which has already been told. Now, menstrual migraine, they are more 2.5 times more during the first 3 phases of the menstruation. And definitely we know that it is not the proestrogen could protect against the menstrual migraine. It's the estrogen withdrawal is a trigger, typically not preceded by the aura, but there can be a transient neurological symptoms of 15%. So if you see, you can use naproxen. It is a very good drug for menstrual migraine, just pre-phase, but zolmitriptan offer a very alternative treatment for the menstrual migraine, and approximate 60% have these attacks during, and already been told that estrogen, there is a loss of serotonin tone because of that estrogen withdrawal. And if you see the result of zolmitriptan, pain relief at 2 hours, pain-free at 2 hours, and recurrence at 2 to 4 hours is very less with zolmitriptan when you are using in the menstrual migraine. It's a very good abortive drug to use during the menstrual migraine. No unexpected side effects resolves without intervention. So it's a wonderful drug to be used. Now coming to the new class of abortive medication, it will be a boom because the only thing when you use a subcutaneous drug once in a month, there is a mindset that you are using an injection for a disease which people consider not the migrainer, but other family members consider that it's not a major disease. But those who are suffering the headache, they know the best that what they are suffering. So if there comes an oral anti-CGRP agent like a Ramizepant, and if you can see the Ramizepant, the freedom from the pain is very high in comparison to the placebo, and it has given the freedom for longer in oral calcitonin gene receptor peptide antagonists. So there are higher pain-free and less bothersome headaches with this drug in the form of oral CGRP. I was part of Eli Lilly trial of this lasmiditan. The only problem with this 5-HT agonist is that the side effect profile, which they have to still, when we used in the trial, there were not alarming things, but still what they propose with this drug, 100, and they are still doing that dose. Both the doses has been used in the trial, in the phase 3 trial of lasmiditan, and it is 100 and 200 milligram. The only thing which is important, why the person is not using the acute abortive therapy, is that when they are taking the drug, they should not feel the bitterness of the drug in comparison to their headache. So they want a relief of the headache, but they don't want a side effect of the drug, what they are taking off. So we have to come with an abortive drug, which is effective very immediately, but not giving the side effect in the form of, because lasmiditan has mentioned the nausea, patient can feel that that photopsia, they are seeing the visual symptoms. That is why when we are doing the trial lasmiditan, we have asked them not to drive after that. So this is what not there with the triptans when we give. We all have seen side effects with triptan, but lasmiditan, that is the main thing they have to come out with the phase 3 trial. How much when they are giving the acute abort, because you can have an acute attack anywhere. When you're driving a car, you can have an acute attack. We ask our migraineurs to keep their acute medication in their purse and in their bag when they are traveling. If they take and they drive at that time, and if you have that photopsia in front of you and you have some blurring, that becomes a major worry. This was a very effective drug in the phase trial when we used it, but only thing that abortive drugs should not have other side effects which when they are used, and triptans are very good in that. So if you don't treat episodic migraine, how it convert in a mixed headache. And when we are a neurologist at a neurologist level, we see patients sometimes not at this level, we see at this level. So at that time, we have to remove them from that abuse of the medical overuse medication. We have to remove them from there. We have to teach them how the lifestyle modification. It's a comprehensive approach. It is not the abortive therapy. It's not the preventive therapy. It is not the overuse of the medication. You have to let them understand what is the lifestyle of the migrainer different from the other people. When I go in sun and I start having headaches. So we have to let them know what precautions they have to take, even they are taking the prophylaxis. So it's a wholesome treatment. It's a comprehensive treatment in the form of lifestyle modification, preventive therapy, and acute therapy if we don't want our patient to get converted into a mixed type of headache. To summarize my talk, migraine is a primary headache disorder, and it is, the severity and the disability with it. It is growing constant in the last few years because the lifestyle has been changed. There is a lot of screen time has been there. Even now, if after this coronavirus, a lot of screen time has increased. So migraine has increased. So empty stomach, lack of sleep, and lock off screen time of these LED, there is a lot of headache increasing. So burden of migraine, to manage the risk factors, non-pharmacological interventions, preventive and abortive therapy. And the future lies with the anti-CGRP monoclonal antibodies and other acute abortive drugs which are coming in the pipeline, and the choice of the acute treatment depending on the severity of the migraine headache, which you should use very judiciously when you're using it. Triptans have established efficacy for moderate and severe attack. Mild to moderate attack, they respond poorly to the NSAID, can be used. And zolmitriptan is a very tolerated agent with efficacy superior to sumatriptan. It's a very good drug for the menstrual drug, and the newer class of oral medications making inroad as abortive treatment, including the oral anti-CGRP and lasmiditan. Thank you very much for the patient listening. I will just come off the... Hello? Are you able to hear me? Thank you very much.
Thank you, Dr. Sharma, for your informative presentation. And this is the time for question and answer.
Okay. Thanks, Professor. Now we are question and answer session. We have a lot of interesting questions here, and the first question came from Dr. Ko, and the question is: how would you differentiate migraine without aura from analgesic overuse headache?
So how you'll differentiate migraine with aura?
Professor Asan, will you answer the question, please?
Analgesic abuse headache solution သူက analgesic ကောက်ထားတဲ့ပေါ့နော် history ရှိရမယ်သူကတစ်နေ့ကိုဆိုလို့ရှိရင်တစ်လမှာဆိုလို့ရှိရင်ရိုး simple analgesic solution တစ်လကို15ရက်နဲ့အထက်ပေါ့နော်ကောက်ထားတာမျိုးရှိရမယ်အဲ့ဒါဆိုလို့ရှိရင်သူ့ analgesic abuse headache လို့ခေါ်ပါတယ်ဟိုပါပေါ့အဲ့ဒီခွဲမဲ့ဆိုလို့ရှိရင်တော့ဒီ drug history ကိုသေချာပြန်မေးရမှာပေါ့နော်သူပါ analgesic တွေတောက်တယ်လေတစ်လမှာရောဘယ်နှခါတောက်ရတယ်လဲပေါ့ဒါတွေပြန်မေးဖို့လိုပါလိမ့်မယ်
Thank you, Professor Asan. Another question is?
The next question came from Dr. Emia is: when should a CT scan can be performed in a patient with chronic headache?
Professor Asan, would you like to answer it?
Yeah, CT scan ကဘယ်လိုပြန်ပြီးတော့နေလောက်ရမလဲဆိုတော့ဆောနာရှိရပြောခဲ့တယ်လို့ပဲပေါ့နော်ဒီ reflex တွေရှိသလား history examination လုပ်ကြည့်ပြီးတဲ့အခါကျတော့မှ snoop ပေါ့နော်အဲ့ဒီမှာကိုကနေပြီးတော့မှဒီ reflex တွေရှိတယ်လို့ထင်တယ်ဆိုလို့ရှိရင်เนาะဒါ CT scan လုပ်ဖို့ indication ရှိလာပြီပေါ့နော်နောက်အဲ့ focus sign ရှိရ snoop ပေါ့ရှေ့မှာပြောခဲ့တယ်လို့ပဲเนาะ symptoms တွေအဲ့ဒါတွေရှိရဆိုလို့ရှိရင်တော့ CT scan လုပ်ဖို့အတွက်ကိုလုပ်ရမယ်နောက်တစ်ခုကကျတော့ migraine လိုမျိုး treat လုပ်နေတယ်ပေါ့နော် migraine အတွက်ကိုလည်းနေစီးတွေပေးနေပါရဲ့နဲ့သူမသက်သာဘူးဆိုလို့ရှိရင်ပေါ့နော်ဒီ frequency တွေပို့ပြီးတော့များလာမယ်ပြီးအခါ severity ပိုဆိုးလာတယ်ဆိုလို့ရှိရင်လည်းဒါ indication for CT ပါပဲ
Thank you.
The next question came from Dr. Yaza is: 46 years old female patient with headache off and on for 2 weeks, which is all over the head was in the morning, no reflex signs, want to stay quietly during attack. She is a stressful person. She also had poor sleep during night. Can this be stress headache? If so, most appropriate treatments, please.
Professor Asan, please.
40သူပြောတာ46နှစ်เนาะဟလာအမျိုးသမီး stress ရှိတယ်ခေါင်းကိုက်တာနှစ်ပတ်ဇက်တိုက်လားဟလာဇက်တိုက်လား
headache ကို off and on လို့ပြောထားပါတယ်မမ
off and on 2 weeks
ဟုတ်ကဲ့မမ
အဲ့ဒါကတကယ်လို့ stress type of the character of headache ကိုပြန်မြင်ရမှာပေါ့နော် throbbing လား unilateral လား bilateral လားဒါမှမဟုတ် tightening လား pressing လားပေါ့နော်ဒီဟင်းဆိုလို့ရှိရင်တော့ tension type headache ဆိုလို့ရှိရင်တော့ရှေ့မှာပြောခဲ့တယ်လို့ပဲသူက tightening ပေါ့နော် pressing ပေါ့ဒီ throbbing လို့မဟုတ်ဘူးပေါ့နော်အဲ့ဒီကြောင့်မလို့ tension type headache ဆိုလို့ရှိရင်တော့ migraine ဆိုလို့ရှိရင်တော့ throbbing type headache ပေါ့ဒီ character ကိုမြင်ရမှာပေါ့နောက်ခါကျတော့သူကaura ကကျတော့ရှိမယ်မရှိဘူးဆိုတာက without aura ဆိုလို့ရှိရင်တော့လည်း aura migraine က aura မရှိဘဲနဲ့လည်းဖြစ်နေတာပေါ့နော်သူ stress ကြောင့်မလို့ဖြစ်တဲ့ဟာလားဆိုတဲ့ဟာတော့အဲ့လိုမျိုး history မှာပြန်မေးရမယ် character of pain ပေါ့နော်သူရဲ့ history က stress ကဒီ stress ရှိလာတော့မှသူဒီ headache ရလာတာလားပြီးလို့ရှိရင်ဒီ character of pain ပေါ့ဒီ pressing tightening လားเนาะ bilateral ဖြစ်နေသလားဒါဆိုလို့ရှိရင်နောက်သူရဲ့ဟိုပါပေါ့ရှိမှပြောခဲ့တယ်လို့ပဲ daily activities ကို limit မဟုတ်ဘူးဆိုလို့ရှိရင်တော့ဒါဒီ migraine မဟုတ်ဘူးဒီ tension type headache ဖြစ်ဖို့ပုံများတာပေါ့နော်
Thank you. Can I have another question?
Yes, Dr. The next question came from Dr. Joshua Wing. How to treat triptan-associated chest and abdominal hot sensation as well as fatigue sensation?
Can you have another question, right? Is it safe to give triptan on?
Yes, Doctor. Again, how to treat triptan?
I'll answer the two together. Okay, Professor Dr. Sharma, please. The first question is how to treat triptan-associated chest and abdominal hot sensation, as well as fatigue sensation. And another question is it safe to give triptan in migraine patient with any type of arrhythmia or ischemic heart disease?
So it is very clear and in our presentation that for the uncontrolled hypertension and arrhythmias or any cardiac disease, it is big no for the triptans. You cannot give triptans for any cardiac condition. You have to be very clear about it. So that is a big no. The first question which they asked, the chest discomfort and abdominal discomfort or sensation, definitely they are there, and if they are significant, you have to either shift to the alternative triptan because different triptans have different category which are effective, and if triptans are causing that, and it is always told you that if acute therapy is giving you more discomfort, it should be removed, and you should look underlying cardiac disease for such patients if they fall in that category, and you should remove the triptans.
Okay, thank you, Dr. Sharma. Another question, please.
Another question came from Dr. Yin. She asked for the three questions. One is role of steroid in migraine. So number two is any difference in treatment between migraine with or without aura. So number three, can triptan useful in vertiginous migraine?
Professor Saimyamyai, would you like to answer the question?
Yeah, thank you for the question. For the first question, the role of steroids, yeah, we have. Definitely, yes, there is the evidence, good evidence, but they recommend only the short course of the steroid therapy. So we never recommend duration more than 7 days. In some studies, they use 3 days regime, 5 days regime, and they have the comparative study. So, but they usually do not recommend in most of these studies more than 7 days. But in some studies, they do 2 weeks, 10 days to 2 weeks. And we can use different types of steroids, prednisolone or dexamethasone, and depending on the severity and the cost you want to, the duration of the treatment you would like to give. So this is for the first question. And second question is the use of the triptans in with or without migraine, with or without aura. There is no difference. We can use in both, and it is effective almost equally. So there is no difference. And for the third question is vertiginous migraine. So triptans is quite useful and effective in vertiginous migraine, but if you don't see the good effect, good response, then we can also use the alternative like the flunarizine or other abortive therapy, depending on the symptoms of the patients and the response. Because sometimes, like one triptan will not respond, but we can switch to the another triptan and see how it goes. So Triptan is useful in the vertiginous migraine as well.
Thank you. Thank you, Senior. Another question, please.
Next questions came from Dr. Ninitro. So, what food should be avoided in migraine?
Can
Any,
I direct you, Mr. Dr. Sharma, please? Yeah.
yes, thank you very much. It's a very pertinent question. See, every part of world has different things for
Yeah.
food. It is not, don't follow West for it, like wine and particular chocolates. Some people get relief by taking chocolates. So don't go into those fixed food criterias that I have seen at my place, that a gastroenterologist having a migraine with a cheese, right? And that is, we call it as a paneer at our place in Indian form, right? And different vegetables. And we have to remember there should not be any coincidence. There should be a correlation of that food every time, where there is a gastric emptying after 2 hours of that food. You should ask your migrainer that it having a headache after that food after 2 hours of that gastric emptying. So don't go on particular fallacies like wine will cause it or chocolate will cause it. So know your own self that which food can. Don't avoid any food just like that.
What about in Burma? Nhiệt độ, nhiệt chiến độ. Chứ hình gì rồi trong xa gì rồi lại sai. Không nghĩ đã cái. Đó là điểm vẫn là phải. But do you think
Hello?
migraine headache in our country? It depends. Even some, the tea leaf, the pet.
Okay.
Yeah, in some person they got a severe headache.
That's very right. That every country has their own.
The different.
Absolutely. Agree with it. Thank you. Wonderful.
Next question came from Dr. Malchik. Has Migo helps on glycemic control?
Mr. Sharma, please. Does Migo have effect on glycemic control?
I'm sorry, can you repeat it again?
Migo, that triptan.
Oh, triptan. Okay.
Any effect on glycemic control?
So we don't have Migo at our place. It's triptan. Yeah. So triptan affect your glycemic control. It's very hard to say, right? That it affects your glycemic level, right? Because it is used in acute form. It is not a chronic therapy. It's not a preventive therapy, right? So for one dose, it may not. But you should know that if you are taking a triptan at that time and if you are feeling lightheadedness, you may have hypoglycemia if you are a diabetic. But diabetics, I always prefer that before giving a triptans, it is a coronary equivalent condition. We have to be very sure before giving the triptans to diabetic. It is not to jump on giving a triptan to a diabetic. It is a coronary equivalent. You should rule out the part of cardiac part for such patients before giving triptans.
Thank you. Any more? Really?
Next question came from Dr. Swami. Any rule of foods like fermented foods and preservative and seasoning powder in triggering migraine?
That's seasoning powder.
Seasonal powder, in some patients.
Fermented food and preservative.
Fermented food.
Yes.
Fermented food and seasoning powder can get migraine.
That's true.
Yes.
Yeah. That we all agree. I think we all agree that those are the foods which are very dangerous for many aspects. One is migraine.
Next question came from the doctor. Is there any chance of ischemic stroke in migraine suffering?
Thank you. Is there any risk of ischemic stroke in migraine sufferer? Not yet. Is there any, the other question is there any chance of ischemic stroke in migraine sufferer? Yep.
Very good question. Very good question. And the person who has asked has a full point, because we have not discussed that part in our talks, right? That more goes towards the complicated migraine. Like the complicated migraine, there is vasoconstriction, but always saying that migraine, if you consider with the autoimmune disease, you should definitely rule out other diseases with that. The hypothyroidism, you know that a lot of people who are migraine, they have hypothyroidism. So migraine as per se, initially, if you see the mechanism, there is a vasospasm. The mechanism by which you're able to hear me, I think there is some sound. Able to hear me? So migraine, when it causes a ischemic stroke, it is the vasospasm which causes the stroke.
Yeah.
Right? That stroke is not because of the atherosclerosis. And if you take care of that vasospasm, we have done CT angio for such patient in the acute attack, and we have found the artery to be there like just Prinzmental angina in cardiac. It is like that in migraineurs, and they can suffer as a complication of the migraine.
And my one comment is there is also evidence that in patient who has migraine, especially with oral, who has the history of taking oral contraceptive pills, that can increase the risk of stroke. So whenever we see patients who are reproductive age who are taking the pills and they do have the migraine, especially with oral, then we have to warn that we have to discuss this issue with that, and we discuss with the obstetrician or gynecologist as well for long-term
Very
use.
good point. Very good point.
Let me add some points. There is a migraine association features. That is the important one is the vasculopathy. Migraine sufferer have a vascular events such as the ischemic heart disease or the vasoconstriction. So they are more prone like to have a stroke, even without occipital or the any other risk factors. Especially the migraine with aura is more prone to this stroke.
Thank you. Thank you, Professor Isa. Another question.
Next question. Next question. Need to read. Yeah. So next question is from Dr. Go again. How would you differentiate migraine from BPPV?
How would you differentiate from benign paroxysmal positional vertigo?
BPPV.
Dr. Isa, would you like to answer? How would you differentiate migraine from benign positional vertigo?
Yeah, sometimes the vertiginous migraine can present with the vertigo without the headache migraine. So in case of the benign paroxysmal vertigo, the vertigo will occur whenever movement of the head. This is the benign paroxysmal vertigo. In case of the vertiginous migraine, they can occur without the positional change, and the vertigo will occur at any position. This is one of the differentiating points.
Thank you. Another question is?
This is came from Dr. P. With caffeine and migraine, bad caffeine marked as stressor for migraine. Please explain.
I'm sorry.
Paracetamol with use in migraine, bad caffeine marked as a stressor for migraine. Please explain about this.
Combination migraine treatment method. Caffeine it depends, no? It depends on the amount of caffeine you take. It depends on, I think it, the question is, paracetamol is fit in migraine, but why you use paracetamol with caffeine combination? In spite of caffeine cause migraine, he is asking about that. It depends upon the amount of caffeine. If you take too much caffeine or too much coffee a day, you can get migraine.
We have another question.
Oh, would you like to answer that, Mr. Chamba?
So we are talking about too much of caffeine causing a migraine. So that is the question. What I know.
The question is that paracetamol with caffeine content combination is used in treatment of migraine.
Oh, got it. It is amount of the caffeine.
Yeah.
I got the info. So the amount of the caffeine which are using. So the person who's asking question, they should know that even the caffeine which you use in a drink sometimes relieves the headache for many people, right? And it can cause but when it is used in a tablet format in the form of paracetamol and caffeine, its doses is totally different. And caffeine has a vasodilatory effect. So it is totally in a different format it is used, not in a form of the high dose of caffeine are given for the migraine. And anyone, other speaker want to answer the question?
Yeah, I agree with you, Dr. Sharma. It depends on the dose of the caffeine, and the combination from the dose is not that high. And sometimes for myself, I'm also a migrainer. Then caffeine can help me a lot, but not too much, because sometimes that's too much caffeine can cause me insomnia, which is the main trigger of migraine for me. So, and too much caffeine can cause vasodilation, and also it can trigger like this. But for the detailed pathophysiology, I couldn't remember properly, but there is no clear-cut cause why that caffeine has, dual effect both on the uh, triggering factor as well as the, relieving factor. But the dose is the main cause.
Our questions are finished, and thanks all dear doctors.
There is no more question. As there is no more question, now it is time for conclusion. And that diagnosis of migraine is a clinical task and is based on a clinical history, physical examination, and fulfillment of the diagnostic criteria. Neuroimaging is not necessary in most patients. However, we recommend neuroimaging for the patient with suspected migraine or non-acute headache who have either an unexplained abnormal grade for neurological examination, atypical headache features, headache that do not fulfill the strict definition of migraine or other primary headache disorder, or some additional risk factor for secondary headache such as immunodeficiency. Current medications should be reviewed as possible exacerbating factors. Consistency of lifestyle, such as diet, caffeine intake, sleep, and exercise should be encouraged, and a strategy for the treatment of acute attacks with triptans, NSAID, combination of these agents should be developed with an emphasis on treating as early as possible after a migraine attack onset. The frequency and can you hear?
Yes.
The frequency and severity of migraine attacks should be monitored to assess whether preventive therapy may be indicated. If pharmacological therapy are ineffective or have unacceptable side effects, neuromodulation approaches should be considered. Today, I would like to thank Professor Asa, Professor Semyamya A, and Dr. Sharma for the excellent presentations, and to the attending doctors from various parts of the country giving their valuable time for the webinar. And I would also like to extend my thanks to Zydus Company for their sponsorship. Thank you. Do you want to say anything, Dr. Sharma? Thank you. Now
Now you please switch on the mic.
I'm extremely sorry. So I just want to thank to the chair, Professor Min Chao, Professor Min Ted, and all the speakers. And I would like to thank Myanmar and the Zydus Cadilla to bring me on board. And it was pleasure interacting with all of you here at Myanmar. Thank you. Thank you very much.
Thank you, Dr. Sharma. Stay safe.
မင်္ဂလာပါကျွန်တော်ကတော့ဒေါက်တာအောင်သက်ဦးပါကောစာ division ရဲ့ division head ဖြစ်ပါတယ်ဒီနေ့ vote of thanks ကိုပြောခွင့်ရတဲ့အတွက်လည်းကျေးဇူးတင်ပါတယ် vote of thanks မပြောခင်မှာကျွန်တော်တို့ Zydus Cadilla အနေနဲ့ Migo launch track ကိုအထူးစီစဉ်လေးတစ်ခုပြုလုပ်ထားပါတယ်အဲ့ဒီအစီအစဉ်ကတော့ကျွန်တော်တို့ seeing is believing ဆိုတဲ့ဆိုရိုးစကားအတိုင်း Migo sample လိုအပ်နေတဲ့ဆရာများအနေနဲ့ click for sample ဆိုတဲ့ click လေးကိုနှိပ်ပေးပါ migraine ရောဂါခံစားနေရတဲ့လူနာတွေမှာစမ်းသပ်ကုသရတဲ့အတွက် Migo ဆေးတစ်ခါပို့ပေးမှာဖြစ်ပါတယ်ကျွန်တော်အနေနဲ့ vote of thanks ကိုအင်္ဂလိပ်လိုရောမြန်မာလိုရောကျွန်တော်ပြောမှာဖြစ်ပါတယ်လေးစားရပါတော့ professor များ chairperson များ speaker များမြန်မာနိုင်ငံအနှံ့မှဆရာဝန်များနဲ့ဧည့်သည်ပေါင်းတို့ကိုမင်္ဂလာပေါင်းနဲ့ပြည့်စုံပါစေနှုတ်ခွန်းဆက်သပါရစေယခုကျင်းပသော Migo ဆေးသစ်မိတ်ဆက်ပွဲမှာကြေးကြောခွင့်ရသည့်အတွက်ဂုဏ်ယူဝင်းမြောက်မိပါတယ် on migraine management 2020 ဆွေးနွေးပွဲတွင်တန်ဖိုးမဖြတ်နိုင်သောအသိပညာများနှင့်အတွေ့အကြုံများကိုမျှဝေဆွေးနွေးပေးပါသော chairperson များနှင့် speaker များကို Zydus Cadilla ကိုစားလှိုက်လဲကျေးဇူးတင်ရှိကြောင်းပြောကြားလိုပါတယ်မြန်မာနိုင်ငံတဝန်းမှာလည်းဒီ Migo launch symposium ကိုတက်ရောက်ပေးကြသောဆရာဝန်များနှင့်ဧည့်သည်တော်များကိုလည်းအထူးကျေးဇူးတင်ပါတယ်ယခုဆွေးနွေးပွဲဖြစ်မြောက်အောင်မြင်ရေးအတွက်အဖက်ဖက်မှလမ်းညွှန်ကူညီဆောင်ရွက်ပေးပါသော Mr. Running အဖွဲ့ Zydus Cadilla အဖွဲ့တို့အားလည်းကျေးဇူးတင်ရှိပါတယ်ယခုဆွေးနွေးပွဲမှာဆေးပညာဖြန့်ဝေမှုများဟာ migraine ရောဂါကိုကုသပေးသောမြန်မာနိုင်ငံတဝန်းဆရာဝန်များအတွက်ထိရောက်သောကုသချက်များကိုရရှိစေပါတယ် Migo ဟာ Zomi Triptan 2.5 mg ဖြစ်ပြီးမြန်မာနိုင်ငံသို့ Zydus Cadilla ဟဲ့မှာပထမဆုံးတင်သွင်းမိတ်ဆက်ခြင်းဖြစ်ပါတယ် Migo ဟာအခြား migraine ဆေးများနဲ့မတူဘဲ migraine ရောဂါ၏လက္ခဏာများကိုသာပျောက်ကင်းစေုံသာမက migraine ကြောင့်ခေါင်းကိုက်ခြင်းကိုလည်းပျောက်ကင်းစေသောတစ်ခုတည်းသောဆေးဖြစ်ပါတယ် Zydus Cadilla ဝန်ထမ်းများမှမြန်မာနိုင်ငံအနှံ့အပြားရှိမြို့ကြီးများနှင့်ဒေသသီးသီးတို့တွင် Migo ကိုဝယ်ယူရရှိနေရန်ဆောင်ရွက်လျက်ရှိပါတယ်တန်ဖိုးချီသောလူကြီးမင်းအားလုံးတို့နေကင်းအချိန်မှာ Migo ဆေးမဆက်ဘက်ကိုတက်ရောက်ပေးခြင်းအတွက်အထူးပင်ကျေးဇူးတင်ဝင်းမြောက်ကြောင်းနှင့် Migo ဆေးဖြင့် migraine ရောဂါများကိုဖြည့်ရစွာပျောက်ကင်းကုသနိုင်ပါစေကြောင်းဆုမွန်ကောင်းတောင်းရင်ညီကုန်းချုပ်ပါတယ် Good afternoon honorable professors chairpersons speakers our most valued invited doctors and guests across Myanmar ladies and gentlemen it's my privilege to have been asked to propose a vote of thanks on this symposium on behalf of Zydus Cadilla Healthcare and on my own behalf extend a very hearty vote of thanks to Chairperson Professor Mimi Cho, Co-Chairperson Professor Women and speakers Professor A for presenting migraine epidemics, Professor Semyamya A for practical tips for acute management of migraine, and Dr. Alin Sharma for presenting landscape of migraine management and treatment. I would like to say thanks again to all of you for sharing your valuable knowledge and experiences on Update Migraine Management 2020. I believe will give new concepts in management of migraine in Myanmar. I also wish to express my gratitude to country head Mr. Ram, Mr. Rajesh, Mr. Shishadri, PMD team and team across Myanmar, as well as Dr. Hardik, Zydus Medical Affairs India for providing encouragement at every point of time in organizing this great event and making a great success. Success of any webinar is a number of participants. I'm happy to state that today's webinar we had registration and attendance over 500 doctors across Myanmar. Thank you each one of you for making Migo launch webinar a grand success. Respected chairpersons, ladies and gentlemen, once again, I want to state that we are almost grateful to chair, co-chair and all speakers on this symposium. We thank all of you for being with us in this afternoon. It's been a great pleasure. Thank you very much. Stay safe, take care, and bye-bye. See you soon.
Thank you. Bye. Shashadri.